Ultra. Good morning. I will be displaying some of the case statements. So please go through it, read it once or twice, and if you can answer the questions, you mark it and keep it with you. Okay? So this will help you to understand the today's topic. The first will be, so read about this case vignette. So here is a 20-year-old man who has been hemorrhaging as a result of gunshot wound. Enters a local emergency department. Okay, so 20-year-old man who is bleeding profusely and he will come to the emergency department. The reason for bleeding is the gunshot wound. On examination, the skin was pale. He had tachycardia, increased heart rate, an arterial pressure of about 60 by 40 millimeters of mercury. Okay, so both systolic and diastolic pressures have been reduced. And he has trouble in walking. Unfortunately, the blood bank is out of whole blood. Okay, the blood bank, there is no stock of whole blood as such. Since the person is bleeding profusely and it has met with an accident, so we need to replace him with the blood. But blood bank, we don't have whole blood. Which therapy would the physician recommend to prevent the shock? Is it the administration of a glucocorticoid? Is it the administration of an antihistamine? Infusion of a balanced electrolyte solution? Infusion of a sympathomimetic drug, or infusion of plasma? Okay, so just take down the few important points. 20-year-old man bleeding profusely because of gunshot wound. Then the signs of tachycardia, hypotension, pale skin. Then he has trouble in walking. So which, and the blood bank, there is no stock of whole blood. So which one of these can act as a treatment, better modality of treatment for this patient? Second one, a 65-year-old man enters a local emergency department a few minutes after receiving an influenza inoculation, that means influenza vaccination. Okay, he has failure, tachycardia, arterial pressure of about 80 by 50 millimeters of mercury, and again trouble in walking. What therapy do you recommend to prevent shock? Okay, so in the previous case also you had observed there was tachycardia, there was hypotension, and he had difficulty in walking. Okay, and the skin was pale. And here also the same symptoms are there, the same signs and symptoms are there. But this is for the influenza vaccination or influenza inoculation. So what do you think the treatment would be? Is it the infusion of whole blood, administration of antihistaminics, infusion of a balanced electrolyte solution, infusion of sympathomimetic drug, administration of tissue plasminogen activator? Okay, so this is case segment 2. Please make a note and you can just roughly mark your answer. Towards the end, I will explain. Then the last and the third case segment, which condition often occurs in a person with progressive hemorrhagic shock? Okay, so which condition often occurs in a person with progressive hemorrhagic shock? So in the first case scenario, you had seen the patient was bleeding profusely. Okay, in case if it is not stopped, then he will further progress to progressive hemorrhagic shock. So this is, so which one do you think? Is it increased capillary permeability? Is it stress relaxation of the veins, tissue acidosis, increased urinary output, increased mean systolic filling pressure? Okay, so please go through all the 3 case vignettes and write down the few important points. If you can answer it, towards the end when I discuss, I will tell the answer. Then you can correct yourself. Okay, so with these scenarios, let me proceed to today's topic, that is the pathophysiology of shock and syncope. A very important topic as far as the day-to-day for doctors. It is very very important because usually we come across many such incidences when you are there in the emergency department. Okay, and you should know what is shock, what are the different types of shock, and what is the basic pathophysiology. So, I will be explaining under these headings. First, let me tell you about brief history about how did the term shock has been introduced. Then followed by different types of shock. Then pathophysiology of shock. Then stages of shock. Compensatory mechanisms. Compensatory mechanisms means even though the person is bleeding profusely, the body will not keep quiet. So, how does the body respond to that? These are called the compensatory mechanisms. Then the clinical features, okay, and finally the treatment. Now, coming to the history. So usually when we tell, you might have observed in movies and all. Suppose if someone tells a very untoward, if some untoward incident has happened, and if he tells someone, suddenly the person will become standstill or he will collapse. So usually we tell he is in shock, okay, or you yourself get to hear any kind of such news. So how do you express? You will tell your friends for few minutes you were shocked, you were not able to express anything, isn't it? So in the same way, this term, the shock was derived from a French word, shock, okay, shock, C-H-O-C. So it is a French word. The meaning is the push or impact, okay, the meaning was push or impact. So this was published in the year 1743 by the physician later on, okay, by the physician later on. So the shock is a French word derived from a French word called the shock, which means push or impact. And there was a belief that the symptoms arose from fear. Okay, someone who is in fear, someone who is scared, whatever the symptoms that person expresses, or some other form of altered cerebral function. So, before in olden days, probably in early 1700, the shock was supposed to be, they used to think it is because of the symptoms which arose from a scared person. Okay, so that was called as shock. And later they also believed that it is because of some cerebral dysfunction or altered brain function. So then they used to call it as a shock. But presently we know shock means it is nothing but it is the circulatory failure. The heart fails to pump the blood, only then we call it as a shock. So coming to the definition of the shock. Shock is a condition in which the cardiovascular system, it fails to perfuse the tissues adequately. As I told, the shock refers to, it is the failure of cardiovascular system. Okay, so that means to tell the main function of the heart is to pump the blood. If the heart is not able to pump the blood, then we call it as a circulatory failure. Circulatory failure refers to shock. Okay, and even if the heart is able to pump the blood, but if it is not adequate, if it is not able to meet the demands of the tissues, then also we call it as a shock. So shock is nothing but it is a condition in which the cardiovascular system, it fails to perfuse the tissues adequately. Impaired tissue perfusion occurs when there is imbalance between the cellular oxygen supply and the cellular oxygen demand. So that means to tell the tissues are demanding for oxygen, the tissues are demanding for nutrients. Heart is able to pump the blood, but it is not able to supply the adequate quantity of oxygen to the tissues, adequate quantity of nutrients to the tissues. So the demand of the tissues is not met by the circulatory system. So then we call it as a shock. So an impaired cardiac pump circulatory system can lead to compromised blood flow to the tissues. So when the heart fails, it will lead to a compromised state of blood flow to the tissues. Now coming to the different types of shock. We have four different types of shock. The hypovolemic shock, the distributive shock, the cardiogenic shock and the obstructive shock. Okay. So there are four different types of shock. The hypovolemic shock, the distributive shock and the cardiogenic shock and the obstructive shock. So first, let me explain one by one. First, we will take up the hypovolemic shock. So hypovolemic shock, it is also called cold shock. You will understand why it is called cold shock. Hypovolemia refers to decrease in the total blood volume is called hypovolemia. So whenever the conditions which can give rise to decrease in the total blood volume, then we call it as hypovolemic shock. So what are the causes for hypovolemic shock? So hypovolemic shock can be because of increased blood loss, as in case of hemorrhage. Okay, so this can be because of increased blood loss, then it is called hemorrhagic shock. If it is because of trauma, road traffic accident, remember the first case we met, he was met with a gunshot injury, or if the person meets with a road traffic accident, so then it will become traumatic shock. Okay, in that case also the person will be losing the blood like anything. So in that can lead to hypovolemic shock. Then burns, the burns, of course it depends on the percentage of burns, and remember in burns the person will not lose the whole blood as such, it is the plasma which the person is going to lose. Okay, and again any decrease in the plasma volume can lead to decrease in the volume of the blood itself. So burns can also lead to hypovolemic shock. And of course the most common condition which is frequently seen in day-to-day life is vomiting and diarrhea. If there is severe vomiting and diarrhea, this can also lead to hypovolemic shock, because there is loss of there is loss of fluid which can reduce the volume of the the vascular compartment, that is the ECF, the extracellular fluid compartment, and this can lead to hypovolemic shock. So among these causes, the hemorrhagic shock is very commonly seen, and this is the best example for the hypovolemic shock. And the other name for hypovolemic shock is the cold shock. Now, coming to the hemorrhagic shock. Hemorrhagic shock, as I told, it is mainly because of loss of blood from the body. And depending on the percentage of blood loss, the hemorrhagic shock can be classified into various types. So we have 4 different categories of hemorrhagic shock depending on the amount of blood loss. If the blood loss is between 0 to 15% of the total blood volume, then we call it as the class 1 hemorrhage. Okay, it is an example for class 1 hemorrhage. Next, if the percentage of blood loss is between 15 to 30, then we call it as the class 2 hemorrhage. If the percentage of blood loss is between 30 to 40%, it is class 3, and if it is more than 40%, we call it as the class 4 hemorrhage. Okay, so it is not the it is not just the blood loss, it is the amount of the blood loss which matters. Okay, depending on the amount of blood loss, the body will start responding to the shock mechanism. So coming to the class 1 hemorrhage, the symptoms which usually presented by the patient will be mild tachycardia, that is increase in the heart rate. So you think physiologically, now the person is losing the blood and it is very minimal. So what is happening? There is decrease in the blood volume, and this because of decrease in the blood volume, there is decrease in the venous return, decrease in the cardiac output, and decrease in the decrease in the blood pressure. So when the blood pressure is decreasing, the tissue perfusion will be affected. Okay, so the tissues will be affected. In order to compensate for this, the heart will start beating at a faster rate. So that is the reason the initial symptom what you see in case of shock is the increase in the heart rate, that is the tachycardia. So next, usually no significant change in the blood pressure, the pulse pressure and respiratory rate in class 1 hemorrhage. In class 2 hemorrhage, of course, there is significant tachycardia, heart rate will be more than 100 beats per minute, and there is tachypnea, followed by there is rapid breathing. Okay, there is increased frequency of respiration, which is called tachypnea, and there is decreased pulse pressure, that means the blood pressure is start decreasing. Then class 3 hemorrhage, when the loss of blood is between 30 to 40% of total blood volume, there is marked tachycardia, tachypnea, decreased the systolic blood pressure and oliguria. So remember here, the systolic blood pressure is the first one to get reduced, because the main determinant of systolic blood pressure, it is the cardiac output or the stroke volume. Okay, so the systolic blood pressure will get reduced. Then oliguria, decreased urine frequency. So oliguria will also result. In the class 4 hemorrhage, when the percentage of blood loss is more than 40%, there is marked tachycardia, there is marked decrease in the systolic blood pressure, narrowed pulse pressure, then markedly reduced, or there is no urinary output, there is complete renal shutdown. The kidney failed to excrete urine, failed to form urine, because the blood flow is so reduced, the kidney is not receiving the blood, it is becoming ischemic, okay, and there is complete reduction in the urinary output, and this is a life threatening scenario, okay. So the person may not recover from this situation and he might die as well. So this is one more diagram to show the relationship between the amount of blood loss with the mean arterial pressure. Remember, in the regulation of blood pressure, I have told, even though we have so many different categories of the regulatory mechanisms or the mechanisms which will try to operate in order to maintain the blood pressure within the normal limits, all those regulatory mechanisms, they are mainly sensitive to mean arterial pressure, okay. So the normally the mean arterial pressure is maintained at about 108 millimeters of mercury. So here they have shown it as 100. So with the different grades of hemorrhagic shock, this is grade 1 hemorrhagic, stage 2 hemorrhagic, stage 3, stage 4. Stage 4 is characterized by more than 40% of the blood loss. Remember, in stage 1, stage 2, stage 3, where the blood loss is up to 30% of the total blood volume, okay, and here the body, the homeostatic mechanisms will try to bring the mean arterial pressure level back to the normal level. So this is called the compensated state of the shock mechanism. Okay, so these are the compensatory stages. These three categories are said to be in the compensatory state or the compensated mechanisms. Okay, so what I can conclude by looking at this graph is, what you can understand by looking at the graph is, if the person loses up to 30% or up to 40% of the total blood volume, the body's homeostatic mechanisms, that is the regulatory mechanisms, will come into picture and they will try to they will operate and they will try to bring the mean arterial pressure from its reduced value to its normal value, and the person can recover from this stage, okay, and this is called the reversible stage or the compensatory stage of the shock. And observe carefully here, if the person continues to lose the blood, and if it is more than the 40% of the total blood volume, so what is happening, it is very difficult. The mean arterial pressure has reduced so much, it has almost become 48 millimeters of mercury, and at this stage the intervention is required. Even if the person receives the treatment also, the person may not recover, and if the mean arterial pressure further continues to fall, if it reaches 60%, even with the whole blood transfusion also, you cannot make the person to survive, because we are not able to bring the mean arterial pressure up to the normal value. So these stages are called the decompensated stage. Okay, so this stage is called the decompensated stage. So this is just to make you understand how important it is to maintain the mean arterial pressure within the normal limits, and it is maintained within the normal limits by various regulatory mechanisms which will operate to maintain the blood pressure. So all the regulatory mechanisms, that is the short-term mechanism, intermediate mechanism, the long-term mechanism, they are very much sensitive to change in the mean arterial pressure. Coming to the pathophysiology of hypovolemic shock. So here, in case of hemorrhage is getting reduced, what will happen? The venous return to the heart will be reduced. So this is going to reduce the end diastolic volume. Okay, if the end diastolic volume is reduced, there is decrease in the stroke volume, there is decrease in the cardiac output, and there is decrease in the arterial pressure. Okay, so because of decrease in the arterial pressure, there is less supply of oxygen to the tissues. Okay, hypoxic state is created. As the oxygen is not available, there is a provision for increased anaerobic glycolysis at the tissues level. Okay, so because of decrease in the arterial blood pressure, there is hypoxic state created at the tissues, and there is increased anaerobic glycolysis, which can lead to the production of increased lactic acid production. and there will be increase in lactic acid production, which will contribute for increase in H plus ion concentration, thereby leading to acidotic condition, acidosis. Okay, when there is acidosis, it will cause depression of the myocardium. Okay, depression of the myocardium, and there is reduced responsiveness of the blood vessels to the catecholamines. Okay, so this this acidosis, it can directly affect the myocardium. Okay, heart and the brain are the most affected organs during the shock mechanism. Even the heart, even though it is flooded with the blood, it is not able to receive the blood. Okay, it is not able to receive the blood, which is causing the depression of the myocardium, and there is reduced responsiveness of the blood vessels to catecholamines. When the blood vessels fail to respond to the catecholamines, that is the adrenaline and noradrenaline, there is no vasoconstriction, there is vasodilation, which will further reduce the perfusion of the tissues. So what are the clinical features you can expect when the person is going in for shock? Okay, so initially, as you have observed in the previous slide, so there is decrease in the blood pressure, that is hypotension, hypotensive state is created. There is both decrease in the systolic blood pressure as well as in the diastolic blood pressure. There is tachycardia, increase in the heart rate, because the heart is not stopping. Heart is trying its best level to maintain the perfusion of the tissue. So it is beating at a faster rate in order to supply nutrients and oxygen to the tissues. And this is characterized by, as there is increase in the heart rate, the pulse will be rapid and steady pulse. So normally, remember in the pulse class we had told, the volume of the pulse will be determined by the degree to which your finger is raised. Okay. So here what is happening? Normally it will come like this and it will go. Okay, so this is the normal volume pulse. But here it will become rapid and thready pulse. It will come, it will touch. You can just observe on your fingers. Okay, rapid and thready pulse. It will come, it will be, heart will be beating at a faster rate. This is rapid and thready. Okay, so and the peripheries will be cold and clammy skin. This is because there is no vasodilatation. So whenever the blood flow is reduced, the peripheries will become cold. Okay, so it is called cold and clammy skin. Because of this clinical appearance, the hypovolemic shock, it is also called cold shock. Okay, and this is a major difference between the hypovolemic shock and the distributive shock, which I will be discussing next. Okay, so distributive shock, that is called warm shock, and hypovolemic shock is called the cold shock, because here the peripheries are cold and clammy skin. So there is tachypnea, increased respiratory rate, and there is restlessness. The person will be person will be confused state. Even the mental, the person will be totally disoriented. He will be restless. Okay, and there is excessive thirst. Of course, this is a mechanism. It is a delayed compensatory mechanisms in order to bring the blood volume to its normal value. The thirst center, which is present in the hypothalamus, that gets stimulated, and it will encourage the person to take more intake of fluids. So this is about hypovolemic shock. Now coming to the next important type, that is the distributive shock, that is the warm shock. So distributive shock is called the warm shock. So distributive means, we have the circulatory system, okay, which is mainly consists of heart and the blood vessels. So the blood gets pulled in the entire circulatory system. Okay. So here what is happening in this type of distributive shock? The cardiac pump, heart and the blood volume are normal, but the blood is not reaching the tissues. So here, of course, there is a normal quantity of blood will be present in the vascular bed, but it is not reaching the tissues. This is because there is complete vasodilatation. There is increase in the diameter of the circulatory tree, or there is increase in the size of the circulatory bed. So when the volume is getting increased, the amount of blood which is present in that volume is comparatively less, and it is not able to reach the tissues because of vasodilatation. So that is the pathophysiology in case of distributive shock. So inadequate perfusion of the tissues through the maldistribution of the blood flow, and there is intravascular volume is maldistributed because of alterations in the blood vessels. That means the blood vessels are completely dilated. Okay, it is completely dilated. You will understand what is the cause for this vasodilatation in different types of distributive shock. And the best examples for the distributive shock, okay, usually are the anaphylactic shock, the septic shock, and the neurogenic shock. So let me explain one by one. What is this neurogenic shock? So neurogenic shock, probably you would have observed during your hematology practicals when you start attending, and initially we start with the blood experiments. Okay, so when we ask you to puncture your finger for the initial few days, some of you looking at the blood itself, you will tend to collapse. Or in the dissection, you might be standing for a long duration and the teacher will be explaining, you all will be standing, and suddenly one student will collapse. So what is the cause for this? This is an example for the neurogenic shock or the vasogenic shock. Okay, so this is an example for vasogenic shock. This is reversible and it is a very milder form of shock and it is easily reversible. Okay, this is mainly because of there is reduction in the vasomotor tone. That means to tell the vasomotor center is inhibited and the vagal nucleus is stimulated. So when the vagus is stimulated, it will decrease the heart rate, it will reduce the blood pressure. So because of which there is imbalance between the parasympathetic nervous system and the sympathetic nervous system, which can stimulate the vascular smooth muscle which are present in the blood vessels. So there is marked vasodilatation. So when the parasympathetic activity is more, so there is decrease in the heart rate, there is decrease in the cardiac output, and there is vasodilatation. So because of it, whatever the amount of blood which is there in the blood vessels, it is not going to reach the tissues. So because of which there is a development of shock. So vasovagal syncope means, suppose if I am standing for a long duration continuously without moving my limbs. So what will happen? Because of the gravity, the blood will start pooling in the lower limbs. The blood will start pooling in the dependent portion. So there is the amount of blood which is returning to the heart will be reduced. Okay, and this is causing me to faint. This is making me to faint, and this is called the vasovagal syncope. So the immediate reaction, what you are supposed to do is, and you might have done in your classes, what you have done, you might have made your friends to lie on the flat, and you would have the person would have recovered within few seconds. Okay. Next, the primary indicator of neurogenic shock is the bradycardia in the early stage, decrease in the heart rate. Unlike the hypovolemic shock, there it was characterized by the tachycardia, but here it is bradycardia. So the next important distributive shock is the anaphylactic shock. So it is a result of severe allergic or antigen antibody reaction. It is the best example for the delayed hypersensitivity reaction, which you will be studying in your microbiology next year. Okay, so it is an example for hypersensitivity reaction. Probably in these days we don't use penicillin more often, but in olden days, before giving penicillin injection, they used to give a test dose. They used to observe for the reaction, is there any redness or any allergic reactions, and then they used to inject penicillin, because that was a drug that was a drug known to cause the anaphylactic reactions, the allergic response. Okay, and this type of shock can also be observed in case of severe infection. Okay, severe infection. Okay, in that case also we can expect anaphylactic shock. And here the reaction causes the release of some of the chemical mediators, especially histamine and serotonin, bradykinin, which causes massive vasodilatation, and there is increase in the capillary permeability as well. In the class you have learned in the capillary circular, whenever the capillary permeability is increased, so there will be oozing or leakage of fluid from the vascular compartment into the interstitial tissues. So this is the cause for anaphylactic shock, where they are going to cause vasodilatation. It is mainly because of the release of histamine, the vasodilatation, that is the serotonin and bradykinin. So the case with this probably the second, okay, that is related to this, the anaphylactic shock. So there the person is receiving influenza inoculation. Following that he will develop shock. Okay, and now you can think of what could be the treatment modality. This hypersensitive reaction is life-threatening. The next important distributive shock is the septic shock. So any type of microorganism which can cause sepsis, okay, which can cause sepsis, especially the most common is the gram-negative bacteria, can lead to septic shock. The best studied, the most commonly seen gram-negative bacterial infections are E. coli, Escherichia coli, Klebsiella and Enterobacter. Okay, so this is mainly because of these microorganisms, they produce toxins, endotoxins, okay, and these, that is the invading microorganisms, they increase vasoactive toxins. These toxins, they produce vasodilatation, okay, and they also increase the permeability of the blood vessels, and thereby leading to decrease they promote the filtration and thereby causing decrease in the fluid volume and leading to shock. So now coming to the syncope. I have already mentioned the vasovagal syncope or the neurogenic syncope. So what is this syncope? Syncope means it is the temporary loss of consciousness, okay, which may be because of many reasons. So in vasovagal syncope you have learned it is mainly because there is imbalance between the parasympathetic nervous system and the sympathetic nervous system. So when the person stands for a longer duration, because of gravity there is pooling of blood in the lower limb. So because of which the person may faint, and this is called the vasovagal syncope. Okay. Next, the postural syncope. Postural syncope means suppose if the person is lying down, that is in the supine position, as soon as he stands, okay, when he stands up from a supine position, again because of gravity there is pooling of the blood, okay, and this is seen in case of autonomic imbalance, okay, and this type of shock is called postural syncope. Micturition syncope. Some of the individuals they will become faint when they pass urine. During the act of micturition, some individuals they faint. This is called micturition syncope. And carotid sinus syncope means usually I have told, okay, bilateral carotid massage, it is very dangerous. If you go on massaging the carotid sinus simultaneously, so what will happen? The person may faint, and sometimes it can lead to it is even lead to fatal condition. So this is carotid syncope. So in those conditions, what will happen? Usually in men you might have seen. So if they who have the habit of wearing the tie regularly, and if it will continuously press on the carotids, and suddenly if it collapses, immediately they will unbutton this shirt, and they will make him lie down. Okay, so that the person can recover fast. So these are some of the examples for syncope. The third important is the cardiogenic shock. So here, as the name itself suggests, the defect is in the heart itself. The impaired ability of the heart to pump the blood can lead to cardiogenic shock. And here the pump failure of the right or the left ventricle, it is very commonly seen. And the most important cause for cardiogenic shock is the myocardial infarction. MI, okay, myocardial infarction, and the most commonly seen MI is the left ventricular anterior myocardial infarction. So in this case, the myocardium, as the myocardium is depressed, as there is this is called the dying heart. So this you can observe here, even though you cannot appreciate. So this is the red area. This is the normal myocardium. So here you can see the left ventricular myocardium, it is dying, it is deprived of the blood supply, it has become ischemic, okay, and it has become infarcted. So because of which it cannot force the blood into the systemic circulation. So this is called cardiogenic shock. Coming to the fourth important type, that is the obstructive shock. Here it may be because of obstruction to the functions of the heart itself, and this can be observed in some of the conditions like cardiac tumors. In case if there is any tumors of the heart, then pulmonary embolism, any aid in the circulation, pulmonary embolism, tension pneumothorax. Tension pneumothorax means the pleura, the lungs. The pleura are filled with some fluid or some air. So because of which the lungs are not able to expand, and it can also be seen in case of cardiac tamponade. So these are some of the examples for obstructive shock. So now you have seen what are the different types of shock and what are the causes for the different types of shock. Now let us see. The person has entered a different, means the person because of some causes he is entering into a stage of shock. Now how does the body will respond to it? The body will respond to it by various regulatory mechanisms. So many mechanisms, so many protective mechanisms are there in order to restore the blood volume. So in that we have immediate mechanism and we have long-term mechanisms. All these mechanisms you have already done. I'll just tell the importance of these mechanisms. So the immediate mechanism, the baroreceptor reflexes. So this is a short-term regulatory mechanism. All the three short-term regulatory mechanisms, they play a very important role in order to bring the mean arterial pressure back to its normal value. So remember, if you remember the baroreceptor reflexes, they are very much sensitive to sudden fall or sudden raise in the blood pressure. Okay, so any sudden raise or fall in the blood pressure, it is sensed by the baroreceptors which are present in the aortic arch and the carotid sinus. They send this, they send the sensation, they send the impulses to the center via the glossopharyngeal nerve and the vagus nerve to the nucleus tractus solitarius or the vasomotor center which is present in the brain stem, and it will modify the output of the vasomotor center, and that is how they regulate the fall or increase in the blood pressure. Next comes the chemoreceptor reflexes. As the tissues, as the blood flow to the chemoreceptors is reduced, there is development of hypoxia hypercapnic state. So because of which the chemoreceptors which are located in the aortic body and the carotid body, they get stimulated and they will try to bring the blood pressure back to the normal value. And if both these short-term regulatory mechanisms fail, and if the blood pressure falls below 60 millimeters of mercury, then it will activate the cerebral ischemic response. Okay, so in cerebral ischemic response, it is a life-saving mechanism, because here there is direct hypoxia of the vasomotor center which will get stimulated, and this is going to increase the sympathetic activity and thereby causing increased sensitivity of there is increased release of these neurotransmitters like adrenaline and noradrenaline, and because of which there is profound vasoconstriction and it will try to increase the blood pressure. So this is a life-saving mechanism or life-protecting mechanism, CNS systemic response. The next comes the circulating vasoconstrictors. Okay, so as there is decrease in the heart rate, decrease in the blood pressure, so and because of these above mentioned regulatory mechanisms, there is increased sympathetic discharge. So because of which there will be increase in the concentration of circulatory vasoconstrictor substances, especially sympathomimetics like adrenaline, noradrenaline. So all these mechanisms, they will immediately come into picture and they will try to rectify or they will try to correct the fall in the blood pressure, and they will try to reverse the shock stage. Okay, suppose in case if these short-term mechanisms fail, then the long-term mechanisms, they come into picture, they will come into action. So here the one important mechanism is the reabsorption of tissue fluids or the reverse fluid shift mechanism. This I had not mentioned in the long-term regulatory mechanism of blood pressure. So now you can understand better because you have learned the stalling forces, you have learned the mechanism of edema, and you have learned the role of hydrostatic pressure and the capillary oncotic, the colloidal osmotic pressure or the oncotic pressure. So what is this reabsorption of tissue fluids? So in case of shock, what is happening? There is decrease in the arterial blood pressure. So this will lead to decrease in the hydrostatic pressure at the arterial end. So normally at the arterial end, so there is a filtration which is occurring because of high hydrostatic pressure, which is more than the colloidal osmotic pressure. But because in case of shock individuals, what will happen? Because of decrease in the arterial blood pressure, the hydrostatic blood pressure will be less than that of colloidal osmotic pressure. Okay, so because of which, what will happen? The fluid will try to escape, and the person will be losing the fluid. So there is decrease in the there is decrease in the fluid vascular compartment volume. So here what is happening? Reabsorption of the tissue fluid, reverse fluid shift mechanism. So normally at the arterial end, as the arterial pressure is decreasing in the shock individuals, the hydrostatic pressure will be reduced. So this will be less than the colloidal osmotic pressure. So what is happening? When the colloidal osmotic pressure, what does it do? It will try to keep the fluid in the vascular compartment. So it will try to take the interstitial fluid into the vascular compartment. So please understand here. So decrease in hydrostatic pressure, because of decrease in the arterial blood pressure, which is less than that of colloidal osmotic pressure, and now it is trying to take the fluid from the interstitial fluid, that is from extravascular space, it is entering into the intravascular compartment. It is trying to replenish the fluid volume in order to maintain the normal blood pressure and in order to maintain the tissue perfusion. So all these mechanisms they are trying to operate in order to maintain the tissue perfusion. Finally, that is only important. So that is about the reverse fluid shift mechanism. Okay, so which is supposed to be occur at the venous end, even at the arterial end also. So there is shifting of fluid from the interstitial space into the vascular compartment, and therefore this mechanism is called reabsorption of tissue fluid, and this plays a very important role in maintaining the fluid volume. Then renal absorption of sodium and water. This is mainly because of activation of renin, angiotensin, aldosterone mechanism, and there is activation of thirst mechanism, and last delayed response is even there is increased in red blood cell production as well as a compensatory mechanism in case of shock. So coming to the renin, angiotensin, aldosterone mechanism, this I have already discussed in detail. So this is a humoral mechanism. Humoral stands for hormone mediated mechanism. Don't think it is humoral immunity. It is a humoral response. Okay. So whenever there is blood loss, there is decrease in the arterial blood pressure. So this decrease in the arterial blood pressure will increase the sympathetic activity. Okay, and this is going to stimulate the adrenal medulla. So first, this decreased blood pressure, it will cause reduced blood flow to the kidney, and it causes the release of renin, and this renin in turn converts angiotensin, this inactive angiotensinogen to angiotensin 1 and angiotensin 2. This angiotensin 2, it acts on the adrenal cortex and causes the release of aldosterone. So this aldosterone, it acts on the renal tubule to cause the retention of sodium and water, and it also acts on the hypothalamus. It acts on the renal tubule to cause the retention of sodium and water in order to increase the blood volume. Next, this aldosterone, this angiotensin 2, it also acts on the hypothalamus, which in turn acts on the posterior pituitary to cause the release of vasopressin. Okay, ADH, antidiuretic hormone. So this is going to stimulate the thirst center, and because of increased reabsorption of sodium and water, and because of increased fluid intake followed by the thirst center stimulation, there is increase in the blood volume, and this is going to increase the central venous pressure and increase in the cardiac output, and thereby causing increase in the arterial blood pressure. So this, because as there is decrease in the arterial pressure, there is stimulation of vasomotor center, which is causing increased sympathetic discharge, and this is going to act as a stimulus for the adrenal medulla to cause the increased secretion of catecholamines, and they are going to bring about the positive effect, positive inotropic, positive bathmotropic, positive dromotropic effects. So this is an example for the long-term regulatory mechanism. Suppose if all these compensatory mechanisms, if they fail to operate, okay, even though all these compensatory mechanisms they have operated, but they fail in order to restore the mean arterial pressure. So in that case, what will happen? So the failure of compensatory response, finally it can lead to death. Okay, that is a stage of irreversible shock followed by death. The cells switch from aerobic to anaerobic metabolism, and there is lactic acid production. This is nothing but progressive stage of the shock. So there is shift in metabolism from aerobic to anaerobic. There is lactic acid production, and the cell function ceases and swells because of increased metabolic acidosis, and the membrane becomes more permeable. Then the electrolytes and fluids seep in and out of the cell. There is failure of sodium potassium pump, which is essential to maintain the normal shape and size of the cell, and there is damage to the mitochondria, which is the powerhouse of the cell, and finally it can lead to death. If low perfusion state persists, it will become irreversible, and finally it will lead to death. So you have learned the compensatory mechanisms and the different types. Now coming to the different stages of shock, this is the summary of what you have learned till now. So initial stage, there are 4 different stages. The first is the initial stage, then comes the compensatory stage, then third is the progressive stage, and last one is the irreversible or the refractory stage. So in the initial stage, the tissues are underperfused. There is just decrease in quantity of oxygen and nutrients which is supplying to the tissues. Then there is mild decrease in cardiac output. there is increased anaerobic metabolism. Then there is building up of lactic acid within the cells leading to acidotic condition. Then in the compensatory stage, this is a reversible shock because here comes the activation of various homeostatic mechanisms, and here the sympathetic nervous system, it is activated by the low cardiac output. So there is increased release of circulatory catecholamines like adrenaline and noradrenaline, and any attempt to compensate for the decreased tissue perfusion, it will be beneficial in this stage. Okay, please remember, any intervention in order to compensate for the decreased tissue perfusion will be beneficial. Then the third is the progressive stage. So failing compensatory mechanisms can lead to the progressive stage of the shock. So here there is profound vasoconstriction. Even though there is profound vasoconstriction from the sympathetic nervous system, there is ischemia and lactic acid production is more. So this will overtake this means this will take a upper hand over the vasoconstriction, and whenever there is accumulation of metabolic waste products, especially like lactic acid, H plus ion, K plus ion, so they all can lead to vasodilatation, and they will worsen the shock, okay, and thereby leading to high metabolic acidosis, okay, so there will be high metabolic acidosis, and this is going to depress the myocardium as well. Then irreversible or refractory stage, this is the cellular. In this stage, there is necrosis of the cells, there is death of the cells, okay, tissues, and there is cellular necrosis, and multiple organ dysfunction can occur, and this will give rise to multiple organ dysfunction syndrome, and death is imminent if the person progresses to the last stage. The refractory stage means he is refractory to the treatment. He will not be responding to the treatment, even though the intervention is done, it will be very late. So the overall features of shock include hypotension, fall in the blood pressure, tachycardia, that is increase in the heart rate, rapid and steady pulse, cold and clammy skin in case of hypovolemic shock, and warm peripheries in case of distributive shock because of profound vasodilatation. Okay, so in case of distributive shock, which may be septic, anaphylactic or neurogenic shock, so there the peripheries are warm, okay, they are not cold. So tachypnea, increased respiratory rate, then the reduced urine output because of renal shutdown, apprehension if the shock means because of reduced hypoxic state which is created in the brain as well, and even at the vasomotor center level, there is an altered sensory and confused state, and finally the person may become unconscious. So coming to the treatment of shock, it is to identify the patient at high risk for shock and to implement the measure to enhance the tissues. Okay, first we need to identify the cause and we have to treat accordingly. The main modality of treatment for the shock is fluid resuscitation. You have already learned the different types of fluids. I have just mentioned few. You can use crystalloids like vinegar lactate or 0.9% sodium, normal saline. Then colloids, albumin-rich colloids, which will try to retain the fluids which is being pushed to the body within the vascular compartment, and thereby they maintain the blood volume. So that is the main role of colloids. Then plasma expanders, they will add on to the volume and they will try to increase the blood volume. Then the blood transfusion. Blood transfusion, of course, it is the treatment modality for the shock, and vasoconstrictors and inotropic drugs are life-saving in case of shock. Vasoconstrictors, they are rapid acting, they are fast acting compared to all other measures, so they are very much needed. Then to control or to eliminate the cause, then in case of septic shock, broad spectrum antibiotics needs to be given in order to control the infection and in order to treat the dysarrhythmia. If it is because of cardiac origin, we need to treat the dysarrhythmias. Then we need to correct the acid-base imbalance because there is a profound acidosis. So we need to correct it. Then we need to maximize the oxygen delivery support because tissues are deprived of oxygen. There is hypoxic state. So we need to supplement them with oxygen and prompt surgical intervention, especially in case of obstructive shock. Okay, if they are suffering from tension pneumothorax, we need to we need to insert the intercostal drainage in order to reduce the tension on the lungs. Okay, so this is about the treatment modality. So this is a chart comparing different types of shock. Anyway, this will be there in this thing, and you can go through it later. Okay, we have this table just compares the three different types of shock: cardiogenic shock, hemorrhagic, and septic shock. Okay, so one important point to highlight here is the blood volume. So remember, in cardiogenic shock, the blood volume is more, and in other shock, the hemorrhagic shock, the blood volume is reduced, and in septic shock also it is reduced. Okay, so this is about the different types of shock with this thing. Now coming to the case Vignet 1. So in that, the patient was 20 years old and he was bleeding profusely and he had signs and symptoms of shock. Okay, he had tachycardia, he had hypotension, he was finding it difficulty in walking, and his extremities were cold and clammy. So of course, it is an example for hypovolemic shock. The best treatment for hypovolemic shock is the whole blood transfusion. Since the blood bank is running out of blood, we have to think of alternative treatment. Okay, so what could be the best modality of treatment? The plasma infusion is the next best therapy for this particular patient. Okay, so in hypovolemic shock, it is the first thing is the blood transfusion. Then if the blood is not available, we have to infuse the patient with plasma. So plasma infusion is the next best therapy because its high colloid osmotic pressure will help the infused fluids to stay in the circulation much longer than would a balanced electrolyte solution. So this is the reason. This is the correct answer for the first case Vignet. Is that clear? Now coming to the case Vignet 2, here the patient had received influenza inoculation. Okay, now presently we are receiving COVID vaccination. Okay, so some of the reactions which can occur because of vaccination, they can give rise to some anaphylactic kind of reaction. So all that they would have studied in the clinical trials. Only when they ensure it is safe in patients or it is safe in healthy individuals, then only it will be recommended after finishing all the clinical trials. Okay, so here the person has received influenza inoculation, but maybe because of some reason he has developed anaphylactic shock. Okay, so here influenza inoculation, he quickly went into shock, and this leads to he is in anaphylactic shock, which is a type of neurogenic or distributive shock. So what exactly happens here? Here there is a release of histamine and bradykinin, other substances which bring about massive vasodilatation. So of course the best modality of treatment in these cases antihistaminics. But since the patient is in shock, antihistaminics, they take longer time to act. They are very slow acting. So, and the patient could die in the meantime. So, the best treatment for this is rapid acting agent which must be used such as sympathomimetic drugs. They are the life-saving drugs in case of anaphylactic shock. Adrenaline should be injected immediately. More than giving antihistaminics. Okay, so this is the second case treatment. So any anaphylactic shock, and if the person is in anaphylactic shock, instead of thinking of first giving antihistaminics, it is better to go for sympathomimetic drugs, that is the adrenaline, which is a life-saving drug in these type of patients. Coming to the third one, this is related to the progressive stage. Okay, progressive stage of shock. So here there is failure of compensatory mechanisms, as you have learned. There is massive acidosis, okay, and there is failure of all the mechanisms, and there is increased capillary permeability will be there. Okay, so just to list out what are the things which can happen in progressive shock is, so there is profuse hypoxia which can lead to severe acidosis, metabolic acidosis, and there is increased capillary permeability because of because of altered Starling process. Okay, so because of severe hypotension. So the fluid can leak out of the vasculature, that is out of the vascular compartment, decreasing the blood volume. So in this case, increased capillary permeability can occur, which allows the fluid to leak out of the vasculature, thereby decreasing the blood volume. Then the second thing is the vasomotor center failure. Okay, so vasomotor center failure because of hypoxia, because of hypoxic state, and there is peripheral circulatory failure and decreased cellular mitochondrial activity and acidosis throughout the body. So tissue pH decreases, and there is reverse stress relaxation of the veins also occurs. Reverse stress relaxation of the veins can also occur. And here usually the urine output strikingly decreases. Okay, therefore increased urinary output answer is incorrect. You will never expect increased urinary output in the progressive stage of shock. That means to tell in the end stage of shock, there is complete renal shutdown. The kidneys will fail to form urine, and the person may die. So this is about the pathophysiology of shock. I hope you have understood. Please analyze these case vignettes and try to think and try to answer. Okay, so this will help you to understand better. Thank you. Yeah, we work
So good morning students. So today's class will be on digestion and absorption of lipids. Okay. So digestion and absorption of lipid. Before going to digestion and absorption of lipid, the last topic which has been left out is riboflavin. Okay. So it is one of the small vitamin, water soluble vitamin. So just in 5 minutes I will complete this riboflavin. Later on we will discuss regarding digestion and absorption of lipid. So riboflavin, so it is a water soluble vitamin containing d orbital linked to dimethyl adenosine. Okay, so this is the chemistry, that is the chemical structure. So this is the d orbital ring, which is the derivative of ribose. So this is linked to nitrogen of the dimethyl adenosine. Together it is called as riboflavin. No need to draw the structure in the exam. So just write d orbital with linked nitrogen atom linked to dimethyl adenosine structure. Together it is called as riboflavin. Okay. So riboflavin is a water soluble vitamin consisting of, which contains d orbital, which is a derivative of ribose, linked to nitrogen of the dimethyl adenosine. Okay. Together it is called as riboflavin. So coming to properties, so it is a heat stable, intense yellow color, which is used as a food additive, that is it acts as a coloring agent for various sweets and various foods. Okay, so this is the property of riboflavin. Chemistry property, simple it is heat stable and which gives the intense yellow color to the food. Okay, so coming to coenzyme form, the coenzyme or the active form of the riboflavin is 2, that is you can see the pointer FMN and FAD, that is flavin mononucleotide and flavin adenine dinucleotide. So these are the 2 active coenzyme form of the riboflavin. Okay, so you have to know what is the active coenzyme form, that is 2, that is FMN, FAD. FMN is nothing but flavin mononucleotide. Okay, FAD is nothing but flavin adenine dinucleotide. How it is synthesized? How the riboflavin is getting converted to its active form? By the enzyme flavokinase. So here it is, whatever the dietary riboflavin it is there. So this riboflavin, with the help of the enzyme flavokinase, okay, utilizing ATP, getting converted to flavin mononucleotide. So again, with the help of the enzyme FAD synthase, that is flavin adenine dinucleotide synthase, utilizing ATP, it is getting converted to FAD, that is nothing but flavin adenine dinucleotide. Okay, so you need to know which is the active coenzyme form, FMN and FAD. How it is being synthesized? With the help of the enzyme flavokinase and with the help of the enzyme FAD. These things you have to write in the exam. So you have to mention the heading as coenzyme form of riboflavin. The active coenzyme form of the riboflavin is FMN and FAD. FMN and FAD is being synthesized with the help of the enzyme flavokinase and FAD synthase. This is the active form, and above the structure also you can see this is ribitol, adenosine, riboflavin, adenosine. Here ATP is being synthesized from FMN, FAD is being synthesized in FAD synthase. So just you need to remember FMN and FAD are the 2 active coenzyme form of the vitamin riboflavin. Okay, so that was the active coenzyme slide. So next coming to biochemical functions. Okay, so simple biochemical function. So this FMN and FAD act as a cofactor for various enzymes. So you need to remember what are the enzymes which are dependent on FMN and FAD. So first thing, so what are the enzymes? Which are the enzymes which are required FMN as cofactor? First thing we will discuss regarding FMN. So FMN is required in 2 important reactions as a cofactor. First important reaction is during oxidation of amino acid, that is during conversion or during oxidation of L-amino acid to ketoacid and ammonia, that is oxidation of amino acid. We require an enzyme L-amino oxidase, L-amino acid oxidase. For this enzyme we require FMN as a cofactor. Okay, first thing is what to do. FMN act as a cofactor for L-amino acid oxidase. So this L-amino acid oxidase is required for oxidation of amino acid, that is conversion of amino acid to keto acid and amino. Okay. So second thing is FMN is an integral component of electron transport chain, that is complex one of an electron transport chain. So electron transport chain is that whatever the reducing equivalent form NAD and FAD is being utilized for production of energy. So for that complex one, so the complex one we require it is FMN as a cofactor. Okay. So because of this part, hence it is used in energy production. Okay, because it is involved in electron transport chain, FMN is required for energy production. Okay, so these are the two important reactions where we require FMN as a cofactor or coenzyme. First thing, L-amino acid oxidase. Second thing is for internal component of complex 1 of electron transport chain. Because of this involvement, so this vitamin is also called as energy production vitamin. Okay, so these two enzymes you need to remember where FMN act as a cofactor. So second thing is FAD, flavin adenine dinucleotide. So this is the another coenzyme of riboflavin. Okay, this is the another FMN is one. Second coenzyme form is FAD. Okay, so FAD is required for various enzyme activity. So it acts as a cofactor for pyruvate dehydrogenase complex. So this is a multi-enzyme complex which helps in conversion of pyruvate to oxaloacetate. Okay, so that thing. So glutathione reductase. So this glutathione reductase is required in our body for glutathione is required for antioxidant property. Okay, for recycling of glutathione in our body, we require an enzyme called glutathione reductase. For this glutathione reductase, FAD acts as a cofactor. Okay, third most important enzyme where FAD acts as a cofactor is succinate dehydrogenase. So this enzyme is required in TCA cycle for conversion of succinate to malate. Okay, so the fourth important enzyme where we require FAD as coenzyme is xanthine oxidase. So this xanthine oxidase is required for conversion of hypoxanthine to xanthine. Later on, this xanthine is getting converted to uric acid. Okay, so these are the four enzymes, that is EDH complex, that is pyruvate dehydrogenase complex, glutathione reductase, succinate dehydrogenase, and xanthine oxidase. These are the four important enzymes we require FAD as a cofactor. For the proper functioning of these four enzymes, we require a cofactor or coenzyme called flavin adenine dinucleotide. Okay, so you should remember the four enzymes and the function of these enzymes, that is pyruvate dehydrogenase complex function is for conversion of pyruvate to oxaloacetate. Okay, second is glutathione reductase. So glutathione reductase is enzyme which is responsible for glutathione recycling in our body. So this glutathione is an important antioxidant. Okay, the important function of this glutathione is antioxidant property. Okay, so this enzyme riboflavin is also has some role in antioxidant property. Okay, the third important enzyme is succinate dehydrogenase. This enzyme is required in TCA cycle for conversion of succinate to malate. The fourth important enzyme is xanthine oxidase. So this enzyme is required for conversion of hypoxanthine to xanthine. Later on, this xanthine is getting converted to uric acid. Clear? So these are the four important enzymes which require FAD as a cofactor. And coming to next, dietary sources. So these are the two enzymes. FMN is required in two important reactions, that is L-amino acid oxidase and electron transport chain. FAD is required in four important enzymes, that is PDS, glutathione reductase, succinate dehydrogenase, and these things. So coming to important dietary sources, so which is present in both vegetable sources as well as non-vegetarian sources. So the main is milk, egg, liver, green leaf vegetable, and yeast. Okay, so these are the good sources of riboflavin. Okay, so coming to recommended dietary allowance, so a normal adult men and women require around 1.5 milligram per day. So this requirement is increased in pregnancy and lactation. Okay. So there in pregnancy and lactation there will be an increased demand. So that is the reason we require around 2 to 4 milligram per day. Okay. Which that is around 1.8 to 2 milligram per day. So additional supplementation of around 0.2 to 0.4 milligram per day is required in pregnancy and lactation. Adult milligram we require around 1.5 milligram per day. So in pregnancy and lactation, due to increased demand, so there should be an extra supplementation of around 0.2 to 0.4 milligram per day. Okay. So coming to deficiency, so what might be the probable cause for deficiency of particular vitamin in a person is, one might be inadequate intake, that might be due to bedridden patient or else any patient who is not taking riboflavin through the diet, so that person will suffer from deficiency manifestation. Alcoholism, so chronic consumption of alcohol leads to decreased absorption of the riboflavin, or else impaired absorption. Impaired absorption of riboflavin might be due to any intestinal disease, okay, celiac disease, okay. So these diseases leads to decreased absorption of dietary riboflavin through the intestine. So these are the three probable causes in which the person might suffer from the deficiency manifestation. Okay. So what are the clinical manifestation which we will see if the person is suffering from the riboflavin deficiency? One is angular stomatitis, that is inflammation and small crack at the angle. You can see inflammation and the crack at the angle of the mouth. Okay. So these features you will see, angular stomatitis, that is inflammation and small crack at the angle of the mouth. Second thing is magnetotongue. Okay. So this is the particular color change of the tongue, that is purplish to red discoloration of the tongue, which is mainly seen due to riboflavin, that is vitamin B2 deficiency. So these are the two important clinical features which are seen in riboflavin deficiency. So the other features is coalescence, that is inflammation of the angle of the mouth, glossitis, that is descommunication and inflammation of the tongue, angular stomatitis. You may also see seborrheic dermatitis, that is the inflammation of the skin, or else the earliest clinical feature is proliferation of bulbar conjunctival capillaries is the earliest sign. So this is the earliest sign, that is proliferation of the bulbar, that is in the eye, conjunctival capillaries. So there is the proliferation of these capillaries. So this is the earliest features. Later on seborrheic dermatitis, glossitis, angular stomatitis, these are the other clinical features seen in the deficiency of the riboflavin. Got to know? So got to know what are the clinical features. So how we will confirm the person by these clinical features? We will do the blood test by confirming the riboflavin deficiency. So there will be decreased RBC, plasma and urinary levels of the riboflavin. So when if you want, so we will see the riboflavin levels in the RBC as well as in the blood as well as in the urinary. So in all these three, the level of the riboflavin will be decreased. Okay. So we will estimate the riboflavin levels in RBCs, plasma and urine. So in all these three, the levels of the riboflavin will be decreased. No need to write the what are the normal levels. You just write the point, that is decreased RBC, plasma and urinary level, as well as there will be decreased glutathione reductase activity. I told you glutathione reductase. So this, for the proper activity of the enzyme glutathione reductase, we require an cofactor riboflavin. Okay. So if there is any deficiency, the activity of this glutathione reductase activity will be decreased in the erythrocyte. So these are the two clinical biochemical findings which will confirm the person is suffering from the deficiency of the riboflavin. Okay, got to know chemistry, dietary sources, whatever it is there. So riboflavin characteristics, chemistry. So active coenzyme form, that is FMN and FAD. Reaction requiring FMN and FAD. So first thing is FMN, we require two important enzymes, that is amino acid oxidase and electron transport chain dehydrogenase. So FAD we require in this proper functioning, that is PDH complex, glutathione reductase, succinate dehydrogenase, xanthine oxidase. Okay, dietary sources RDA in pregnancy and lactation and adult man, deficiency causes, deficiency manifestation, and biochemical. So this is about the riboflavin. So this ends the water soluble vitamins. So we almost discussed water soluble, every water soluble vitamins. So vitamins chapters. So it is very important chapter. So you may get the long essay as well as many cases you will get here. Vitamin. What we should know, what are fat soluble vitamins, what are water soluble vitamins, and what are the properties of fat soluble and water soluble vitamins, which was discussed in the earlier classes. So individual vitamin you should study in detail. It might be fat soluble or water soluble, A, D, E, K. Okay. So various case studies will be there. As also deficiency manifestation will be asked. Okay. So in detail it will carry around 15 to 20 marks. Okay. So in detail you have to study regarding fat and water soluble vitamins. So you refer to the other books on Coenzyme's various previous year question papers. So what are the questions which are asked on the fat and water soluble vitamins, and recent you refer to the various books regarding which all the cases can be asked on fat and water soluble vitamins. Okay, so that ends the water soluble vitamins. Coming to next topic, that is lipid metabolism. So in the last month or last month I have discussed regarding various aspects of chemistry of lipids. In the chemistry of lipids, I told you what are lipids, how these lipids are classified. Okay, lipids are nothing but the heterogeneous group of compounds, different group of compounds which are assembled together based on the common property, that is lipid, water insoluble and soluble in various alcohols. So that was the definition of lipids. So based on the composition, the lipids are classified as triacylglycerol, phospholipid, simple lipids, complex lipid, and derived lipids. Okay, so that was so today we will discuss regarding the digestion and absorption of lipids. Okay, so before going to this, I told you what are lipids, how they are classified. Lipids are nothing but the heterogeneous group of compound which are grouped under similar classes, that is based on common property, that is water insoluble and soluble in organic solvent like ether and alcohol. So that those compounds are called as lipids. So there are lipids, complex lipid and derived lipid. Simple lipids are nothing but esters of fatty acid and alcohol. Okay, so that the most common simple lipid is triacylglycerol. Complex lipid is nothing but the esters of fatty acid along with alcohol with an extra group attached. Okay, based on the extra group attached, those complex lipid might be phospholipid, glycolipid, and if the phospholipid is attached, that is called as phospholipid. If the carbohydrate might is attached, that lipid is called as glycolipid. Okay, so coming to digestion and absorption of lipid, simple topic it is there. So whatever the diet you are taking, whatever the lipids you are taking through the diet, so you need to know where it is absorbed and which are the enzymes which are responsible for breakdown of that lipids. So it is very simple. So dietary intake of lipids, so a normal person will consume around 40 to 80 grams per day. Okay, a normal adult person will consume a lipid diet around 40 to 80 grams per day. So the lipid which is present in the diet include, so in that 40 to 80 gram, 90% of that 40 to 80 gram will be neutral fat, that is triacylglycerol or triglyceride. Okay, so the rest percentage will be around fatty acid, phospholipid, glycolipid, steroids, and fat soluble vitamins. So this fat soluble vitamin is a miscellaneous. So these are the other fats which we consume. 90% of 40 to 80% will be around triglycerol, fatty acid, phospholipid, glycolipid, and steroid. Okay, so these are the lipids which are present in our various foods, oily foods, whatever the food we consume. Okay, that food contains around 90% of triglyceride, fatty acid and phospholipid. Okay. Coming to sources, so what are the dietary sources which contain fat? That is triacylglycerol. So this triacylglycerol is mainly present in vegetable oils like groundnut oil, sunflower oil, various vegetarian sources, or else non-vegetarian food include meat and fish. Okay, so these are the various important sources of triacylglycerol or lipids through our diet. The phospholipids also contain various plants and animal sources. So through these sources, we consume lipid through the diet. So it might be in the source of oil, it might be in the source of milk, it might be source of dairy product, it might be source of vegetable, or it might be source of meat, fish. Phospholipid sources include various plants and animal sources, mostly include vegetables, meat and all. So through these sources we consume lipids through the diet. Okay. So what will happen after consuming will be discussed in next few classes. So digestion and absorption is little bit complex process. It is not easy as carbohydrate and protein just because of one reason, that is due to hydrophobic in nature. These lipids are not soluble in water. Due to this process, due to this property of lipid, that is hydrophobic property of lipid, so it is bit a complex process compared to carbohydrate and protein. Okay, because it is a hydrophobic in nature. So whatever you will consume, so just have a look what will happen after consumption of lipid through the diet. So digestion in mouth and stomach. So through mouth you are taking through the diet. So in mouth there is little or no digestion occurs in the mouth or stomach. Why? Because due to short stay of food, whatever food we are taking, so this food, whatever the lipid we are taking through the diet, so that lipid will stay in our mouth in a short period, very short period will stay. So that is the reason there is little or no digestion occurs in the tongue. That is no significant, no importance of, no significant digestion is taking place in the mouth. Okay, even though there is no significant, you need to know the role of two enzymes in mouth and gastric. Okay, so lingual lipase is an enzyme which is secreted by the Ebiner's gland in the dorsum of the tongue. Okay, so this has some activity or some action on the dietary lipid. So that is not significant, but you should mention the enzyme name, that is lingual lipase, which is secreted mainly through the Ebiner's gland in the dorsum of the tongue. Okay, so this, even though this enzyme is secreted in the mouth, but it has some activity in the stomach. This, it will not act in the mouth, so this will go to the stomach due to acidic pH. So this, it is active in the acidic pH environment. So as the stomach pH is acidic, so there it will go and act on the like lipids on the stomach. Okay, so gastric lipase. So this gastric lipase is mainly synthesized or secreted by the parietal cell of the stomach. Okay, so this has very short or very small role in short and medium chain triacylglycerol. Short and medium chain triacyl. So this gastric lipase will act on short and medium chain of triacylglycerol, mainly in the children's. Okay, mainly in the children's. So this short and medium chain triacylglycerol which is present in the milk. Okay, so this has very small role in adult. So in children it has various activity. It has activity on short and medium chain of triacylglycerol, which is mainly present in the milk. Okay, so you just need to mention the enzyme, that is lingual lipase and gastric lipase. Okay, and their role. Lingual lipase has no significant role in the digestion of the lipid, and gastric lipase, it has very small role in short and medium chain triacylglycerol, which is present mainly in the milk and only in the children. Okay, so coming to digestion in the small intestine. So this thing you should know. So whatever the dietary fat you are consuming through the diet, so maximum 90% of the fat is being digested and absorbed through the small intestine, mainly through the duodenum. So as the food has been passed from the mouth and stomach, now as the food reaches the duodenum, okay, now food reaches the duodenum. So pancreatic enzymes, pancreatic secretion, mainly in the form of enzymes, and bile juice. So this bile juice provide alkaline medium for the enzyme action, that is enzyme of pancreatic enzyme action. okay, enters the duodenum. So whenever the food reaches the duodenum, so the secretion of the pancreas, that is mainly pancreatic enzyme, as well as the bile, okay, through the bile, okay, enter to the duodenum through common bile duct, okay. So food is coming through the stomach and entering to the duodenum, and simultaneously pancreatic enzyme as well as the bile juice enters the duodenum through the common bile duct, okay. So here you should know the role of bile salt. The role bile salt, that is act as an emulsifying agent. Emulsification is a process in which the large fat droplets is being converted to small fat droplets. Okay, that is carried out mainly by the bile salt. Okay, so you need to know. So after reaching there, now in the duodenum, food is there, pancreatic enzyme is there, as well as bile juice is there. The role of bile juice is to provide the alkaline medium for the proper actioning of the pancreatic enzymes. Okay, so now the role of bile salt is to act as an emulsifying agent, that is conversion of large droplet of fat to small droplet fat. Okay, so after that, so in the intestine, you see various pancreatic enzymes. So here the first important enzyme is pancreatic lipase. So this lipase act on the triglyceride, whatever the dietary triglyceride is there, it will act on triglyceride. So there will be cleavage of fatty acid which is present on the C1 and C3. Okay, so in the duodenum, pancreatic lipase will act on the triacylglycerol. Okay, so this triglycerol is being fluid. Ester bond is this pancreatic lipase will fluid the ester bond and release the fatty acid from carbon number 1 and carbon number 3. Okay, you can see here. This is triacylglycerol. Okay, major dietary lipid. So pancreatic lipase will act in the duodenum. So this will fluid to form 2 monoacyl glycerol and fatty acid. You can see the difference in the structure. So this structure is being removed. R1 fatty acid is being removed and R3. Only R2 is left out. So this is left out R2 and alcohol together, it is called as 2 monoacyl glycerol plus fatty acid. Okay. You have taken triacylglycerol through the diet. So in mouth and stomach there is little or no activity. Okay. Then it has been reached, the food is being reached to the small intestine. So when the food reaches the small intestine, various secretion from the pancreas and bile comes to the duodenum. Okay. Then pancreatic lipase will act on the dietary triacylglycerol. So this lipase will cleave the ester bond which is present on the C1 and C3 to form an 2 monoacyl glycerol and fatty acid. Okay. Next is what are the dietary phospholipids we have taken through the diet. So in the intestine, this phospholipase activity, A2 phospholipase A2 act on the glycerophospholipid to form the lysophospholipid and fatty acid. You can see the structure. Okay, this structure is being removed. This fatty acid which is present on the C2 is being removed to form the lysophospholipid and fatty acid. Okay, so next is cholesterol. Whatever the cholesterol ester which I have taken through the diet. Okay, so cholesterol esterase will cleave the cholesterol ester to form cholesterol and fatty acid. Clear? Simple it is there. So these things you have taken through the diet. These lipids which are taken through the diet, triacylglycerol, fatty acid, phospholipid and cholesterol. These things you have taken through the diet. Okay. So after taking through the diet, so the food in the mouth and stomach, it has not significantly digested or absorbed. Okay. Because next, when the food reaches to the duodenum or small intestine, various pancreatic enzymes will be secreted in the duodenum. Okay, various pancreatic enzymes like lipase, this pancreatic lipase, phospholipase and cholesterol esterase. So these are the various pancreatic enzymes which reach the duodenum and those will act in the duodenum. And bile juice provide the alkaline medium for the proper activity of the pancreatic enzymes. Okay, so bile salt act as an emulsant. These three roles you should remember. Okay, now what has been left? We have got free fatty acid. Okay, free cholesterol we have got by the action of cholesterol esterase. Okay, then 2 monoacyl glycerol. This is the product formed after the cleavage of triacylglycerol and lysophospholipid. So this is the product formed during after the action of lipase Okay, these are the various product form. Okay, so absorption after cleavage, absorption occur at the upper part of the small intestine. These together with bile salt formed a mixed micelle. Mixed micelle is nothing but the conversion of insoluble to soluble form. As fats are insoluble, so after the mixing of bile salt through this, it forms a micelle formation. Okay, so along with this micelle, fat soluble vitamins like A, D, E, K also packed to form a micelles. Okay. So here it is there. So this is an intestinal lumen. This is an intestinal lumen. So above this intestinal lumen, stomach was there, mouth was there. So through mouth you have taken diet of triacylglycerol, phospholipid, and cholesterol. Okay, those lipid diet you have taken. So there was no significant change of this lipid in the mouth and stomach. So when the lipid reaches the intestinal lumen, that is duodenum, so pancreatic enzymes are being secreted. So that pancreatic enzymes acted on the triacylglycerol, cholesterol, and phospholipid to form these products. That is 2-monoacylglycerol. It is an product formed after the breakdown of triacylglycerol in the intestinal lumen. So this is the 2-monoacylglycerol formed from the triacylglycerol in the intestinal lumen by the action of the enzyme pancreatic ligase. Fatty acid, you all know fatty acid. Okay, cholesterol. So this is formed by the action of the enzyme cholesterol esterase. Cholesterol esterase cleaved the dietary cholesterol to form cholesterol, lysophospholipid, and this thing. So this lumen, okay, this is the intestinal mucosal cell. This is intestinal mucosal cell. These things are being degraded. So these will be absorbed by the intestinal mucosal brush border. Okay, in the intestinal brush border of the cell, these being absorbed. So after absorption, so there will be again resynthesis. Okay, so when it is being absorbed, there will be again resynthesis. That fatty acid will get activated, and these activated fatty acid get incorporated into the structure. That is 2-monoacylglycerol to form triglyceride. Again fatty acid. Okay, again cholesterol ester to form cholesterol esterase. Lysophospholipid to form phospholipid. Again, these will be resynthesized in the intestinal lumen. Again, fatty acid will get joined here to form triacylglycerol. So together, these resynthesized lipids will goes and bind to apolipoprotein B48 to form a chylomicron. So this chylomicron enters the lymphatic system. So through this lymphatic system, it will enter through the thoracic duct and through general circulation. This is how lipids being digested and absorbed. Okay, simple it is there. Triacylglycerol, cholesterol, and phospholipid you have taken through the diet. In mouth and stomach, there is no significant changes. When the food reaches from the stomach to the intestinal lumen, that is duodenum, various pancreatic enzymes will act on the lipid. So, okay, so pancreatic lipase will act on the triglyceride to form 2-monoacylglyceride. Okay, to form fatty acid. Cholesterol esterase will act on the dietary cholesterol to form cholesterol and fatty acid. Okay, phospholipase A to act on the dietary phospholipid to form the lysophospholipid and fatty acid. Okay, so these are being cleaved. So these cleaved parts will be absorbed through the intestinal brush border of the cell. Okay, so after reaching the intestinal mucous cell, again fatty acid will get activated. Again those fatty acid will help in resynthesizing of triglyceride, cholesterol esterase, phospholipid along with ADE. Here we require a bile salt to form a mixed micelle, that is conversion of insoluble to soluble form. After absorption, it will goes and bind to apolipoprotein to form a chylomicron. So this chylomicron will be absorbed through lymphatic system. It enters the thoracic duct. Through thoracic duct, it enters to the general cell. Clear? This is how it is being digested and absorbed. This is the process of digestion and absorption of the lipid. So coming to abnormality, what will happen if there is any abnormality in the lipid digestion and absorption? So that condition is called as lipid malabsorption. So lipid malabsorption result in loss of lipid as much as 30 gram per day. Okay, if there is any loss of lipid through the 30 gram per day, along with that fat soluble vitamin and fatty acid through the feces. Mainly it is being 30 gram of fat is being lost through the feces. That condition is called a steatorrhea. Steatorrhea. You should remember that is a steatorrhea. That is a condition in which excretion of fat through the feces. Okay, through feces, fats will be excreted. So that condition is called as steatorrhea. You should know which are the condition which leads to steatorrhea. Steatorrhea is caused by number of conditions. The most important causes is bile salt deficiency. Okay, so this bile salt deficiency occur mainly in liver diseases or due to obstruction to the bile duct. So if there is any bile salt deficiency or in liver disease, or if there is any bile duct obstruction, so this bile salt will not reach to the intestine, will not reach to the duodenum. So there will be no emulsification. Okay, so there will be no absorption. That time it will be excreted through the feces. Okay, first thing, bile salt deficiency. Second thing is pancreatic enzyme deficiency. Okay, so occurs mainly in the infection of the pancreas or else in cystic fibrosis. So these two conditions, there will be no pancreatic enzyme, so there will be no digestion of the lipids. Okay, that time there will be excretion of lipid, whatever the dietary lipids you have taken, so that dietary lipid will be excreted to the feces. Okay. Second thing is defective chylomicron synthesis occur in congenital. As I told you, what is the role of chylomicron here? Here there is no chylomicron, so there will be defective absorption leading to defective excretion of the fat through the stool. Okay. Clear? Third is impaired mucosal uptake. If there is any intestinal celiac disease, there will be impaired mucosal uptake. So these are the various common causes leading to excretion of fat through the feces. How we will diagnose? So measurement of 24-hour fecal fat excretion. Okay, normally around excretion of fat will be around 7 gram for 24 hours. If there is any steatorrhea, this 7 gram will be increased. Okay, measurement of 24-hour fecal fat excretion is the diagnostic point to remember. Treatment is, you should treat the underlying cause, that is, you should, if there is any liver disease, we should treat the liver disease. If there is any obstruction to the bile flow, you should treat the obstruction of the, you should treat for that obstruction of the bile flow. If there is any pancreatic enzyme deficiency, if there is any pancreatic disease, you should treat the pancreatitis. Okay, if there is any small intestinal disease, you should treat. You should treat the above laying causes. Okay, okay. Or else fat restriction diet is also helpful. Okay. The last point is administration of instead of long chain triacylglycerol, you can supplement a fat of medium and short chain triacylglycerol. Okay, this will be helpful for steatorrhea. Clear? So coming to these things, simple it is there. Digestion and absorption of lipid will be asked for 5 marks. So if it is being asked for 5 marks, digestion and absorption of lipid, we should write that dietary lipids, digestion and absorption, whatever the food we are taking, whatever the lipid we are taking through the diet, how it is being digested and absorbed. We should explain those points. So before explaining those points, you should remember what are the dietary sources. That is 90% of how much diet we are taking. It is around 40 to 80 gram per day lipid we are taking through the diet. Out of that 40 to 80 gram, it contains around 90% of triglyceride, fatty acid, phospholipid, glycolipid, cholesterol and oleisin. So these are the various dietary sources of lipid, include vegetable oils, vegetarian sources, green leaf vegetable and non-veg source also are rich in lipid. Okay. So coming to next, digestion. So there is no role of mouth and stomach in the digestion of triacylglycerol. So it has no significant role. Okay. Only two enzymes should mention, that is lingual lipase, which is secreted by the Abinner's gland from the dorsum of the tongue, but not significant. Gastric lipase, which is secreted by the stomach cells. So this has some action on short and medium chain triacylglycerol, which is mainly present in the milk. These 2 points you should mention. Next is 90% or 95% of the lipids are being digested and absorbed by the intestine, that is small intestine. As the food reaches the intestine, various pancreatic enzyme and bile secretion reach there and they perform their function. So pancreatic enzymes include pancreatic lipase, So this pancreatic lipase will leave the triacylglycerol to form monoacylglycerol and fatty acid. Glycerophospholipid and lysophospholipid. Cholesterol will leave to form cholesterol and fatty acid. So these are the product formed after the action of the pancreatic enzyme. So these product forms are being absorbed by the intestinal mucosa, that is brush border. So again these will be resynthesized to form triacylglycerol, cholesterol ester, phospholipid. So together it will bind with apolipoprotein to form an chylomicron. Through chylomicron it is being absorbed by the lymphatic system. Lymphatic system through thoracic duct. Through thoracic duct it enters the general circulation. If there is any defect in absorption and digestion, so that will lead to excretion of fat through the feces. That condition is called as steatorrhea. So these are the various causes for steatorrhea, that is bile salt deficiency, pancreatic enzyme deficiency, these things, and you should write the diagram. Okay, so this ends the digestion and absorption of fat. From the next class, we will be discussing regarding the metabolism of fatty acid. Metabolism of fatty acid is very important topic. So various n number of long questions, that is 10 marks question will be asked, or 5 marks, 3 marks, various case studies will be this thing. So from next, before going to digestion and before going to metabolism of lipids, you should just have a look on chemistry of lipids, that is what are lipids, definition of lipids, how they are classified, what is the significance of their classification, that is simple lipids, complex lipid and derived lipids. Just have a look and we will discuss the metabolism of lipid in the next class. Okay, so we should study both, that is fat soluble and water soluble vitamin, as well as the digestion and absorption of it. Thank you.
Good afternoon, dear students. So today we'll be seeing the dissection of intercostal space. What are its contents? That is the muscle, external intercostal, internal intercostal muscle, and where the intercostal nerve lies in the intercostal space. What are the contents of that? That is your intercostal nerve, artery, and vein. Also, we will see the reflections of the pleura. Okay. If you have any doubts regarding this, kindly post it in the chat.
This is the intercostal muscles itself. I will stretch the legs here, and this is what I have done. And you can see the muscles which are immediately visible in front of us. This muscle is an external intercostal muscle. If you look at the mesh of fibers, you can see two things about the mesh of fibers. Number one, the mesh of fibers are roughly parallel to the slope of the ribs, roughly, not exactly. And secondly, the mesh of fibers are as if the person can put his hands in his pocket. Now this is a very important concept. When the mesh of fibers, the muscle is almost parallel or closely matching the mesh of the sloping of the ribs, then this muscle reflects. It is responsible for aeration of the ribs during post-respiration. Now let's continue with the external. We have reflected a little bit of the external muscle here, and you can see the internal muscle here, apart from here. And you can see that here also, under the external intercostal membrane. The internal intercostal muscle, the rational fibers, as you can clearly see here, is at right angles to the rational fibers, the external intercostal muscle. And I want you here for your comparison. This is the external intercostal, this is the internal intercostal. Because the rational fibers are opposite, this is being likened to as if the person has got his hands crossed to the opposite chest. These internal intercostal muscles, they have been divided into two parts. One portion is between the bony part of the ribs. That portion is referred to as the interosseous part. And there is another part which is shown here, which is between the cardiogenic part of the ribs. And that is referred to as the intercostal part. The two of them have different functions. Even though they are part of the same muscle, the interosseous part of the internal intercostal muscle when it contracts, it is responsible for depression of the ribs during post-respiration. However, when the intercostal part of the same muscle when it contracts, it is responsible for elevation of the ribs. And how does this work? As I mentioned, when the rational fibers are at right angles to the long axis of the slope of the ribs, their contraction will cause depression of the ribs. But in this case, in the intercostal part, we can see that the rational fibers are closely matching the long axis of the cartilages. Therefore, when they contract, they are responsible for elevation of the ribs. So that's the unique point I want to mention about the function of the internal intercostal. This is another section we saw the external and internal intercostal muscles in another diagram from a different perspective. In between the ribs, you can see these muscles here. These are the intercostal muscles. We have three layers of muscles, all of which the outer and the second layers are the most prominent, and we have reflected them in certain places. We have cut the intercostal space here, and we lifted up this. This is the external intercostal muscle. The rational fibers, the external intercostal muscle, as you can see, they are as if hands in the pocket. They go from the rib above obliquely down to the rib. And in forced respiration, they are responsible for elevation of the ribs. They start from the medianmost margin and actually they stop at the liver as an external intercostal membrane. In this intercostal space, you can see much more clearly, and I have separated the means of cardiac muscle, and you can see the external intercostal muscle clearly here. Another external intercostal muscle here next is the internal intercostal muscle. And you can see that the rational fibers of the internal intercostal muscle is exactly at right angles to the external intercostal muscle. The internal intercostal muscle, the rational fibers are as if hands across to the opposite chest. Here, posteriorly, the internal intercostal muscle is deficient and it is replaced by a membrane, which is referred to as an internal intercostal membrane. But anteriorly, it continues right up to the sternum. The internal intercostal is responsible for depressing the interosseous part of the rib during post-respiration. Due to that, will be a very poorly defined muscle, but we cannot see that here, and it's called the subposterior muscle, which is in relation to the angle of the rib. inner circles. That's part of the innermost intercostal. Thank you very much for watching the standard science. If you have any questions, please feel free to let us. Quick demonstration of the anti-chest one, which we have in the So you can see strand here, the anti strand. So this is the trigger branch, the suprastrand branch. And here there's a patient space, which is referred to as the suprastrand space of burns, which we shall see in the neck. This is the mandatory strand of the fluid. And this is where it aggregates the body of the strand. And this region that we feel in the body of the strand is the fusion of the strand brain. And this portion that you see here is the Ssims process. So this is the subcostal angle. Ssims process is found in the digestion. This ambulation angle of fluid is where the second rib is attached. This is the first rib, and this is the articulation with the clavicule. So sternoclavicular joint, and this is the sternocostal joints. And these are the second, third, fourth, fifth, sixth, seventh ribs. Seventh rib articulates with the CT sternum. So these are the two ribs. If you know the ribs, this is the bony portion of the rib, and this is the cartilaginous portion. The bony portion and the cartilaginous portion. So this is the articulation, the sternocostal articulation is right next to the cartilage. So this is the interosseous part, and this is the intercostal part of the spaces. How do we measure the spaces? The usual starting point is the mandatory sternal angle of the way which we can all feel. So once we feel that, then we know that this is second. So the space is known as the second space. And then we have third space, fourth space, fifth space, seventh space, so that's the way to do it. So this is a quick demonstration of the overall overview. The ribs are the bony portion is covered by diastolic, the cartilaginous portion is covered by pericardium, which I shall mention in the clinical correlations just later. This is the pericardium, which we have stated. Now let's take a look at the muscles. The muscle that we see in front of us is the intercostal muscle. These are the external intercostal muscles. And you can see the directional fibers are parallel to the slope of the ribs. This is the external intercostal muscle. It's like as if we have got a hand on top. Therefore, the contraction of the external intercostal muscles are responsible for elevation of the ribs during the course of this stage. Anteriorly, the external intercostal muscle is absent, and I have lifted up a membrane here. You can see the same thing on this side also. So this is the external intercostal membrane. So the anterior portion, the cartilaginous portion of the external intercostal muscle is absent. It is replaced by a membrane. In one place, we have removed the external intercostal muscle. This is the external intercostal muscle to show you the underlying muscle. And this is the internal intercostal muscle. And you can see that the direction of fibers of the internal intercostal muscle is in the opposite direction. It is like as if we put a hand in the opposite chest wall. The internal intercostal muscle has got two components. One portion which is between the bony portion of the ribs is called the interosseous part. The internal intercostal muscle contains right up to the sternum. And this portion that you see here is the intercostal. This portion, bony part, interosseous part, is responsible for depression because it is at right angles to the slope of the ribs. While the intercostal part, because it is parallel to the slope of the cartilaginous part, it is responsible for elevation of the ribs. The internal intercostal muscle posteriorly does not extend up to the vertebra, and then it is replaced by the internal intercostal membrane. So this is what we can see. Now I will turn this specimen to show the inner surface of the appendage is formed from inside. So again you can see inner surface of the appendage with two muscles attached to it, which are actually muscles of the neck, the sternum and the sternum muscles respectively. This is again the mandibular sternum joint. This is the body of the sternum, and this is the xiphoid process. The parts to be noted are this surface that you can see on this side. This is the endothoracic patient. which is covered by the parietal in the classification of the parietal pleura. We can see a mindset. First of all, on this side, we remove some of these superficial structures to show you these types of muscle fibers. This is the transverse thoracic muscle. It is present over the anterior surface. Similarly, it is on this side also, and you can see some of the fibers here. So this fiber is an anterior transverse thoracic. This is the one which contributes to the development and merges with the transverse thoracic muscle. The next three attributes are these two pleurovascular structures on either side. The vein on the medial side and artery on the lateral side. Vein on the medial side and artery on the lateral side. This is the internal thoracic artery and the internal thoracic is very important. This arises on the subclavian artery on either side and it runs down the either side of the sternum. And as it descends down, it disappears between the transverse thoracic and the internal muscle, which is for that activity, and this is disappearing. This is what which is responsible for giving the anterior intercostal vessels, artery and vein. So up to the sixth phase, we have the branches coming from the internal thoracic artery. For number 7, 8, and 9, so that I have split open the transverse thoracic here, and I will be in that here. So I will be that here on this side, and this is the other side open. And we can see that the internal thoracic artery is divided into several branches. This and this. This is the musculoparietal branch. This is the non-vernal branch. Other branch is the superior diastolic branch. Similarly, on this side also, we have split it open to show you the division. As we look at it, and we have seen the division here, we can see the musculoparietal and the superior branch. So that means the intercostal arteries on the anterior aspect. As I mentioned, the first 6 cases are given by the internal thoracic. The 7, 8, and 9 cases, they are given by the muscular. Similarly, on this side also, the 7, 8, and 9 anterior intercostal arteries are given by the muscular. And these anterior intercostal arteries, they run in the neurovascular plate and then they come to the posterior and transverse with the posterior intercostal arteries. So that's another thing which I want to show you on this surface. Now let me mention a few important clinical motivations. Let me turn the table again. We can do, when we are doing any procedure in the muscle space, you have to remember that this is the lower part of the riboflavin and this is the upper part of the riboflavin. Here we have the main universal frontal running and here we have the lateral system. So we have to understand both. And when we are doing a procedure, we have to avoid all the universal structures. So this is the place where we insert our instrument, either the main or the intercostal tube. That is one part. That is the intercostal chest tube drainage for thoracic disease. When we are doing a thoracotomy, we can do an anterior thoracotomy, and the procedure for that is to split open the pericardium as you can see by making an H-shaped incision at that angle, another H-shaped incision at the down on the sides. And that way we can split open the pericardium and we can shell out the arterial portion, and then we can enter the system. So this is the procedure for the anterior. If we want to do posterior lateral thoracotomy, this is not posterior part, just for that, we demonstrate it on this. We do a similar thing. We split the periosteum here, and we lift the periosteum on this side, and we remove the rib in the periosteum. That way we can get advantage of the space above and space below. We will try in the difference. So that is done for posterior lateral thoracotomy and anterior thoracotomy. Let's again back to mention something about the clinical correlation between the internal thoracic artery. That is very important. This internal thoracic artery is used for coronary bypass grafting, and that is known as, especially the left side is used. And that is known as, this internal thoracic also is known as the internal artery because it is very important. Porphyritic branches is something that press to the female as opposed to the mammary artery, and therefore this bypass is done using the left internal thoracic artery mammary is referred as the left internal mammary stenosis. So So these are some of the points we mentioned about the chest wall, about the external surface and the internal surface. Thank you very much for watching. Dr. Sanjay Sayas, signing off.
I have to stop until we got.
These are just small but a beautiful statement. Okay, very. Scientists are process parametric. So this is going to be a demonstration of the posterior aspect of the thoracic wall, from the seat and piece. I'm standing on the right side, so I can look at the process on the right side. So we are doing the entry chest wall, which is shown here. We are doing the heart, we are doing the lungs. So this is the posterior aspect, this is the superior aspect. Let's focus on these neurovascular structures that you can see on the right side and the neurovascular structures that you can see on the left side. Collection of structures which we have picked up here. This is the intercostal neurovascular structures. And they follow regular pattern. The topmost is the vein, just under that is the artery, and then we have the same thing is seen here, and all the spaces. These neurovascular structures, they are running in a shallow groove on the surface of the bed of bone, that's on the postal groove, and therefore they are partially rotated. So let's take one by one. Let's start with them. There are 12 intercostal nerves, the west one is called the subcostal nerve, but some of them are atypical nerves. The first one is an atypical nerve because it does not have lateral cutaneous branch, it does not have anterior cutaneous branch. The second one is also atypical because it has got a very large lateral cutaneous branch. And I will show it to you. We can see this branch coming out. This is the lateral cutaneous branch coming from the second intercostal space. This is called the intercostal nerve. This supplies the chest wall as well as the medial side of the arm. And this is the one which is responsible for recurrent pain in entire pelvis. The other way we nerves are 7 to 11 because they go to the abdomen, they are called parietal nerves. And the third one, as I said, this is intercostal nerve. What are the branches of a typical intercostal nerve? The first two branches are the thoracic sympathetic trunk, and this is the thoracic sympathetic trunk here. And this elevation that we see here, this is the ganglion. So it gives two connections to each ganglion, they are called diagonal ganglions, the brain and all ganglions. The next set of branches are the branch which comes below, and you can see that here. This is called the collateral branch. The collateral branch runs in relation to the upper boundary of the brain, and that is present in all the spaces. Then, of course, we have multiple muscular branches for the muscles, but it gives two notable branches. One is on the mid-axillary line, is the cutaneous branch, and just as sternal line, next to the sternum, it gives a branch which pierces through the muscle. That is from the anterior cutaneous branch, and you can see some anterior cutaneous branches if you look carefully here. They are present on either side of the sternum. So these are the branches of the intercostal nerves. This is an axial modeling of the thoracic segment to show the distribution of intercostal nerves. When we have Puppy's hostel is a reactivation of cardiogenic. The reactivation phase of the vascular virus, they travels down these branches and releases signals about the intercostal space. And that is what is referred to as axial hostel or This is the photograph of axial hostel shingles. This is the intercostal space. When we do the thoracic procedure, we have to make sure we do not damage the neurovascular structures, which are in relation to the lower part of the peripheral. At the same time, we also have to safeguard the collateral branches. And we also have to anesthetize. Usually, we have anesthetized two adjacent segments in order to get complete anesthesia because there can be some overlap of fibers. So this is about the intercostal nerve. Now let's come to the vein. This is the main anatomy. There are 12 intercostal veins, firstly. On the right side, the first posterior vein, as you can see, is not draining into the regular place, it is going down. The first one is called superior intercostal vein. It drains into the right vagus artery, which is this one here. The second one, fourth spaces, they are referred to as superior intercostal vein. They drain into the ascending vein. And the rest of the vein is individual. So this is the drainage on the right side. Now we should take a look at the drainage on the left side. Now we should be on the left side here. And camera process of the left side. So we can see the same process on the left side. And here we can see more clearly, we can see the vein, we can see the nerve, and then we can see the artery, which I showed you just now. On the left side, we can see this vein. This is the hemorrhagic. The hemorrhagic vein receives the lower four posterior veins. Then we can see yet another vein. This is the accessory hemorrhagic. Accessory hemorrhagic is formed by the mid four posterior veins behind. The hemorrhagic opens just below the pH, and then accessory hemorrhagic is just above pH, and both of them open into the ascending state, which I have written here. And you can see it's opening here in the ascending state. What about the upper four posterior veins? The superior intercostal on the left side. They are unite and they open independently into the left radius artery. This is range of the posterior intercostal veins. Right side, mostly they drain the ascendus, left side they drain the ascendus and accessory ascendus. Now let's come to the artery. We remain on the left side. Arteries are located between the vein and nerve, and we can see that clearly here. The artery can be identified only in these cyclic it is thicker and is located. This is one posterior artery. This is another posterior artery. This is yet another posterior artery that we can see here. These intercostal arteries are in two different sets. One set also in the thoracic, and as they come out, they give the thoracic branch, which I mentioned earlier, which comes in relation to the rib. So now two sets of arteries are going like this. And I'm going to bring the anterior just for you. On the inner surface of the anterior wall, we have this artery running here. This is the internal thoracic artery. And you can see it is continuing as the muscular artery. The internal thoracic artery of the 6 veins gives two anterior intercostal arteries. The muscular artery gives two anterior intercostal arteries from the 7th to the 9th space. The 10th and the 12th spaces do not have any anterior intercostal arteries. So the two anterior intercostal arteries from the front and the posterior intercostal artery and the collateral branch from the back, they all have smooths. Most of the blood flows from the posterior to the anterior. Here we have very unique situation that happens in the region of coagulation of Pleura. Coagulation is a congenital damage of Pleura, which happens usually after the ductus arteriosus. So we have added here. That's called post-ductal coagulation. This portion characterizes heart, and once it is narrowed, there is no blood flow to the rest of the heart. So we have to compensate for this type of blood flow. What happens is the internal thoracic arteries, they become very prominent. They get a blood supply, and the blood flow goes through the anterior intercostal arteries. They go in the reverse direction. They go through the posterior intercostal arteries and they go back to the heart. And that's how this is left. That produces extreme dilation of the posterior intercostal arteries, and they become even more tortuous. That leads to notching of the inferior part of the ribs, which is a very important sign of coagulation.
This gestation dilated posterior arteries with notching of the ribs and coagulation.
At the same time, these posterior arteries are very dilated. They are supposed to the person's scapula or taking the scapula. When you put your hand there, you feel the pulsation, that is dancing scapula. So that's another finding that you can see in coagulation of nerve. These are all because of extreme dilation of the posterior intermuscular arteries. This collateral branch applies not only to the arteries, they also apply to nerves and the veins, which we have already mentioned. Before I conclude about the neuromuscular structures, I just need to tell you, give an overview of what was located on the posterior aspect of the human chest. This was formed by two layers, both of which we have removed. One was the shiny layer, which is the innermost, and the parietal. We have removed it in both states. And once we remove that, we have another layer tissue layer with a little bit of fat. And that is in the medial classification, which is outside the parietal layer. And once we remove that, then we need to set out the neuromuscular structures. muscles. And on removing it, now we can see some muscles. We can see these muscle fibers here. These are the innermost intercostal and subcostal muscles. And we can see the same thing here also. We can see these muscle fibers here. These are the innermost intercostal and subcostal. This innermost intercostal and subcostal muscle they constitute the third layer of the chest wall. And we notice that these neuromuscular structures are disappearing inside it. So therefore, the space between the third layer is the innermost intercostal or the subcostal and the internal intercostal that is considered as the neuromuscular area, which is visible only when we remove the endothoracic patient. So that's the what we can see in the posterior thoracic wall with its neuromuscular structures and the clinical correlations and the bit of opportunity such as side.
So you have seen how the thoracic cage is formed. Anteriorly you have the sternum with the ribs attaching to that. You have seen what are the types of ribs. So the ribs get attached to the sternum with the help of costal cartilages. Ribs from 8th, 9th, 10th of the, they are attached, they form the costal margin. 11th and 12th ribs do not get attached to the sternum and hence they are called as free ribs. So in the intercostal space, you need to identify the intercostal muscles. So they are easily and best identified with the direction of their fibers, muscle fibers. So external intercostal will be running downwards, forwards and medially, whereas internal intercostal runs in the opposite direction. The anterior intercostal membrane is formed by the external intercostal muscle, whereas the posterior intercostal membrane is formed by the internal intercostal muscles. So in the plane between that, you have the intercostal nerves, arteries and veins running at the lower border of each rib, what is called as the costal groove. You are seeing the video there. So the intercostal arteries and veins are of different branches, mainly arising from the aorta. The veins also drain into the azygous and hemiazygous veins, which we will be studying in detail in posterior mediastinum. Intercostal nerves, we've already studied the structure of a typical intercostal nerve, how the rami joins to form, giving rise to ventral ramus and dorsal ramus, which supplies the skin. So area of skin supplied by a single spinal nerve will be called as a dermatome. So that is already studied in your general anatomy. Now coming to the pleura. So once you see the thoracic cage in your dissection, what you will be doing is, you have reflected the anterior pectoral region muscles, that is your pectoralis major and minor. Beneath that you are seeing the thoracic cage. Next we will be cutting the ribs along the mid-axillary line, okay, disarticulating the sternoclavicular joint and also the acromioclavicular joint, and we reflect the entire anterior chest wall downwards so that you can enter the thoracic cavity. Once you enter the thoracic cavity, there on either side you will be seeing the two respiratory organs, that is the lungs, and in the center you are seeing a structure what is called as the mediastinum. So the space between the two lungs is termed as mediastinum, which we will be studying in subsequent classes. So the lungs now is being covered by a serous membrane which is called as pleura. You will not be able to just pick up, you will be able to just pick the pleura a little bit. It is in close approximation with the lungs. So you will have two types of pleura there, parietal pleura and visceral pleura. So the space between them is called as the pleural cavity, which contains very minimal amount of fluid normally. Okay, so what you need to study with respect to pleura is the reflections of the pleura. So how the part of the pleura which covers the costal surface of the lung is called costal pleura. The one which covers the medial surface is mediastinal pleura, and one which covers the undersurface is the diaphragmatic pleura. So surface marking of pleura is important for you. So how the costo-mediastinal reflection occurs along the sternum, from which rib, then how the costodiaphragmatic recess from the sternum in the mid-clavicular line, mid-axillary line and posteriorly, which rib it is occurring, that is important for you to know on both sides. And since heart is present most towards the left side, so what is the difference in reflection in the costo-mediastinal pleura with respect to right side and left side? That is important for you to know. And also the recesses of the pleura. So the separation between the parietal and visceral pleura will give rise to pleural recesses. Clinically important is your costodiaphragmatic recess, where the fluid tends to accumulate in infectious conditions, and that is known as pleural effusion. So also, what is the correct way? How should you insert the needle, and what are the structures pierced by that when you enter the pleural cavity, which that is called as thoracocentesis. So what should you be doing that? So you've done that in yesterday's assignment and submitted. So in case you have any doubts, you can get back to us. We'll be very happy to clear that. Okay. So go through these videos once again. So in yesterday's theory class, you've already seen what are the tracings of the costal pleura. So this shall be the costo-mediastinal reflection. So beginning from your sternoclavicular joints, extending all to the sternal angle, and then the ziphisternal joint on the right side. And as on the left side, it deviates a little bit from the fourth intercostal space, extending upon to the sixth intercostal space, isn't it? And costovertebral behind, extending from the 7th cervical spine till the 12th thoracic spine. So how do you count the spines behind? So at the base of your neck, you have the vertebra prominence or the 7th cervical spine. So beginning from that, you can count your thoracic spines, and with that, you will be able to identify the spaces. So costodiaphragmatic reflection, so that is the where the costal pleura continues as your diaphragmatic pleura. So this constitutes to the 8th rib in the midclavicular line, 10th rib in the mid-axillary line, and 12th rib posteriorly. Whereas the lung is 2 ribs below that. So this space which is formed here will be called as your costodiaphragmatic recess. Okay. So this part which covers this part covering the medial surface of the lung will be called mediastinal pleura, covering this surface of the lung. So you can see the rib impressions there. So that will be called as the costal pleura, and covering this part is your diaphragmatic pleura. Okay. So this you are seeing here is the costodiaphragmatic recess. Now these recesses cannot be shown in actuality. Only when it is fluid filled it will be evident for you. This will be best seen if you have a pleural effusion. Okay, when it is filled with fluid. So only schematic representations can be shown here. Okay. So you can see here, this is showing an X-ray collection of fluid here in this pleural cavity, that is called as your pleural effusion. So you can see here, on the normal side, you can clearly make out the angle between the diaphragm and the lungs here, but here this margin has been obscured. That is because of the presence of fluid, and this indicates the presence of a pleural effusion. So you can see here, almost the right side half of the lung has been, there is no air shadow there, that is because of the presence of fluid. Now also you can have presence of pus in the this one which is called as pyothorax, or it can be blood hemothorax, or presence of air following rupture of any lungs, that is called as hemothorax. Okay. blood in this is called as hemothorax. Lymphatic fluid present within this will be called as chylothorax, and presence of air which will compress onto your lungs and cause breathing difficulties, that will be called as pneumothorax. Okay. So any doubts, kindly post it in the group so that we can discuss regarding the same. Thank you.
Messi, Messi,
ಸರಿ ಇದೆ
ಲೂಸ್ ಆಯಿತು ಆಫ್ ಮಾಡಿದ್ರೆ
ಇಲ್ಲ ನಾನು ಬ್ಲ್ಯಾಂಕ್ ಅದು ನನಗೆ ಏನು ಮಾಡ್ತೀನಿ ಅದೆಲ್ಲ ಹಾಕ್ಬೇಕು
ಇದು ಅಷ್ಟೇ ಲಾಸ್ಟ್
ಬ್ಲ್ಯಾಂಕ್ ಗೊತ್ತಿಲ್ಲ ನೀನು ಬ್ಲ್ಯಾಂಕ್ ಇನ್ನೊಂದ್ಸತಿ ಅದು ಬರುತ್ತೆ ಸರ್ ಒಂದು ನಿಮಿಷ ಏನು ಗೊತ್ತಾ ಇದು ಅರ್ಧ ಗಂಟೆ ಪಾಸ್ ಇದು ಅರ್ಧ ಗಂಟೆ ಆದಮೇಲೆ ನೀವು ಪಾಸ್ ಮಾಡಬೇಕು ಸ್ಕ್ರೀನ್ ಎತ್ತಿರ್ತೀನಿ ನೋಡಿ ಬೇಕಾದ್ರೆ ಸ್ಕ್ರೀನ್ ತೆಗಿತೀನಿ ಇಲ್ಲ ಅಂದರೆ ಆಗಬೇಕಾಗಿಲ್ಲ ನಿಮ್ಗೆ ಹೇಳ್ತೀನಿ ಇಲ್ಲೇ ಇರ್ತೀರಲ್ಲ
ಸೌಂಡು ನಾನು ಇದ್ದೇನೆ
Good afternoon, dear students. Today we have the last part of cardiovascular system, that is the heart failure. So we shall study, this is a very small topic for you for at the first year level. We will be just studying what are the different types of heart failure. In brief, we will study what is the pathophysiology of heart failure, very much in brief, and what are the gross treatment aspects for heart failure. Okay. So, followed by this class, we will have a small practical session for about 15 minutes. Okay. Practicals is on effect of posture on blood pressure. Okay. So, first we will start with the theory aspect of heart failure. What do you mean by heart failure? It is a pathophysiological state of the heart when cardiac performance is too low in order to maintain the cardiac output to meet the demands of the metabolizing tissue. I repeat, heart failure is a pathophysiological state of the heart when cardiac performance, that is the pumping action of the heart, is too low in order to maintain the cardiac output to meet the demands of the tissues. Coming to the pathophysiology, cardiac failure occurs most importantly in three situations, or grossly we can categorize the pathophysiology of heart failure into three categories. One is increase in preload. Increase in preload means the amount of blood that is going to be filled into the ventricles before it is going to pump. That is called as preload. Okay. If there is increase in blood accumulation inside the ventricles before it is going to pump, before the ventricular systole occurs, that is called as preload. So, if there is increase in preload, what happens? According to Frank Starling's law of heart, an increase in preload, that is end diastolic volume, should increase the cardiac function. It should increase the force of contraction of the heart. But that occurs only under physiological limits. When there is too much of increase in preload beyond the physiological limit, then it leads to ventricular dilatation and the heart failure occurs. So, I repeat, whenever there is increase in end diastolic volume of the heart, that is increase in preload beyond the physiological limits. Until physiological limits, there should be increase in force of contraction and the blood will be pumped out. But beyond physiological limits, if there is increase in preload, cardiac dysfunction occurs. It leads to ventricular dilatation and finally heart failure occurs. So, this is one important aspect which causes cardiac failure. Second is increase in afterload, that is the resistance offered by the aortic vessels or the major vessels for the pumping action of the ventricles. So, ventricle has to do overwork, it has to increase its pressure over and beyond its normal pressure in order to pump blood into the major vessels. That is called increase in afterload or increase in resistance in the major vessels against which heart has to forcefully contract in order to pump blood. So, this is called increase in afterload or increase in resistance. Best example for this is hypertension. In case of hypertension, there is resistance to the outflow of blood from the heart, which is going to cause overstretching. Increase in work of ventricles will lead to overstretching and ventricular dilatation occurs and finally leads to heart failure. Third and one more important aspect is reduction in myocardial contractility. There is decrease in pumping ability of the heart which leads to decrease in the cardiac output. The interaction of these three variables, increase in preload, increase in afterload and reduction in myocardial pumping ability or myocardial contractility. All these three
may lead to development of cardiac failure. In a gist, we have increase in afterload caused due to systemic hypertension, aortic valve stenosis, coarctation of aorta. Coarctation means narrowing of the aorta. All these leads to increase in afterload. At the same time, cardiomyopathy of the left ventricles, or in case if there is myocardial infarction or heart attack, which leads to loss of some part of the cardiac tissue or cardiac muscle, death occurs. So this leads to reduced myocardial contractility. So increase in afterload, reduced myocardial contractility, both of them lead to left ventricular systolic dysfunction. Left ventricular systolic dysfunction, which in turn leads to left heart failure. Similarly, mitral stenosis. Mitral stenosis means the valves present between the left atrium and left ventricle. We call it as mitral valves. So if there is stenosis or the opening of these valves becomes difficult, that is called as mitral stenosis. Or if there is constrictive pericarditis, both of them lead to left heart failure. Then left ventricular hypertrophy and some types of cardiomyopathy also lead to left ventricular diastolic dysfunction, where the ventricles cannot relax adequately during the diastole. This is left ventricular diastolic dysfunction. This also leads to left heart failure. Then, now let us see what are the different types of heart failures and what are the causes of heart failure. Heart failure can be classified by various ways. There are different ways in which we can categorize the heart failures. Depending upon the onset, whether it is sudden in onset or gradual in onset, we have two types, that is acute heart failure and chronic heart failure. Acute heart failure develops suddenly, for example, in a patient with myocardial infarction. A patient undergoes heart attack, patient has a heart attack, immediately some part of the cardiac muscle gets necrosed and that part of cardiac muscle becomes dysfunction. So that leads to acute heart failure. Chronic heart failure develops due to gradual deterioration of heart functions, as in patients who are suffering from valvular heart disease. Then, depending on the operation of compensatory mechanisms, whether it is a compensated type of heart failure or non-compensated type of heart failure. Compensated heart failure means there is impairment of cardiac performance, which is going to be compensated by certain adaptive changes that is going to prevent the development of the symptoms of heart failure, or overall heart failure symptoms will be masked by this compensatory mechanism. The changes, the adaptive changes that occurs in case of compensated heart failure is again of two types. One is called local changes. Local changes in the form of enlargement of heart chambers, myocardial hypertrophy and increase in heart rate. Now what is enlargement of heart chambers? The heart chamber itself expands. Whereas myocardial hypertrophy, in myocardial hypertrophy, the thickness of the ventricular walls becomes more. This is the difference between these two. The chambers enlarged, the lumen gets enlarged, whereas hypertrophy, the thickness of the walls of the ventricle becomes more. Or increase in heart rate. These are some of the local changes that occurs in case of compensated heart failure. Now systemic changes. So in systemic changes, there is release of certain hormones and enzymes, activation of renin, angiotensin, aldosterone system, and also sympathetic overactivity occurs. There is also release of antidiuretic hormone and atrial natriuretic peptide. So all these are systemic changes. Initially, these compensatory changes will try to improve the performance of the heart. But as the disease progresses, these are going to fail. The compensatory mechanisms fails, and in turn these compensatory mechanism will produce a counterproductive mechanism. It is going to harm or it is going to increase the symptoms of heart failure instead of compensating for it. So this is about the systemic changes. Now, decreased cardiac output. Whenever there is heart failure or decreased cardiac output, two compensatory mechanisms occurs. One is the local changes, which leads to enlargement of heart chamber, myocardial hypertrophy, increased heart rate. And there is systemic changes in the form of increased sympathetic activity, increase in renin-angiotensin mechanism, and increase in ADH hormone. Now, what does these do? Increased sympathetic activity is going to increase the heart rate, so that more and more blood is going to be pumped out in order to maintain the sufficiency of tissue perfusion. It also leads to increase in myocardial activity and increased vasoconstriction. The increased vasoconstriction tries to bring in more and more blood from the periphery back to the heart. That is, arteriolar constriction as well as venous constriction occurs. This tries to increase the preload. It tries to increase the venous return and preload so that it maintains the cardiac output, increases the stroke volume. Now, what does renin-angiotensin mechanism do? It is going to cause vasoconstriction. Again, increase in vasoconstriction tries to increase the venous return and cardiac output. Increase in ADH hormone is going to increase the circulatory volume. There is more and more reabsorption of water. So this leads to increase in circulatory volume, increased venous return, increased end diastolic volume. So according to Frank Starling's law, it should increase the stroke volume. These are some of the compensatory changes that occurs in the early part of the heart failure. Then we have the decompensated or overert heart failure. In the presence of certain precipitating factors, for example, infections, anemia, pregnancy, thyrotoxicosis, arrhythmia, myocardial infarction, or due to failure of the compensatory mechanisms, the compensated heart failure will further progress to decompensated heart failure. Other types of heart failures, we have left heart failure and right heart failure. Depending upon the involvement of which side of the heart, we have left-sided heart failure or the right-sided heart failure. Left heart failure refers to decrease in left ventricular output, whereas right heart failure, it is decrease in right ventricular output. Left ventricular outflow obstruction is due to systemic hypertension, coaptation of aorta, aortic valve stenosis. All these can lead to left ventricular outflow obstruction and left ventricular failure. Also, left ventricular inflow obstruction due to mitral stenosis. Reduced ventricular contractility as occurs in cardiomyopathy or in case of some types of myocardial infarction. We call it as anterior wall myocardial infarction. These are some of the causes for left heart failure. What happens in left heart failure? The left ventricle fails to pump adequate amount of blood into the systemic circulation. Coming to right heart failure is a condition in which there is reduction in right ventricular output. Right ventricle is going to fail to pump adequate amount of blood into the lungs, into the pulmonary circulation. This leads to rise in the right ventricular pressure and also right atrial pressure. This forms a back pressure. So right ventricular pressure increases, followed by which right atrial pressure increases, which further causes rise in jugular venous pressure. It also leads to edema, congestive hepatomegaly, the enlargement of the liver, congestion of viscera except lungs. So this is called as right heart failure. Biventricular failure, or it is also called congestive heart failure, where both the ventricles are not functioning adequately in order to pump blood. In this condition, there is simultaneous involvement of both right as well as left heart due to diseases of the myocardium or left ventricular failure, which in turn leads to back pressure, increase in left atrial pressure, followed by which there is increase in pulmonary artery pressure, followed by which there is increase in the right ventricular and right atrial pressure. This is called as back pressures. This in turn leads to biventricular heart failure. Depending upon the inadequate cardiac output, we can categorize into forward heart failure and backward heart failure. Forward heart failure results due to inadequate cardiac output. Backward heart failure is one in which there is decreased cardiac output, which results in increase in the end diastolic volume. This increases the ventricular pressure. Elevation of left and right ventricular pressure results in pulmonary artery pressure increase and systemic congestion. So what I explained just now, we also call it as backward heart failure. Now, backward heart failure, I explained in the previous slide also. There is increase in the ventricular pressure, left ventricular pressure, which is going to increase the pressures backward. How the blood flows? Blood flows from right atrium, right ventricle, pulmonary circulation, left atrium, left ventricle, right? But here there is the left ventricular pressure is increased, so backward pressure goes on increasing. This is called backward heart failure. Then we have two important types of heart failures, that is systolic heart failure and diastolic heart failure. Systolic heart failure occurs due to poor myocardial contractility. Systole means contraction, right? So whenever the heart fails to contract adequately, we call it as systolic heart failure. Diastolic heart failure results due to poor ventricular filling. Diastole is relaxation of the heart. Heart is not adequately relaxing. So because heart is not adequately relaxing, the ventricular filling is not adequate. So because ventricular filling is not adequate, cardiac output will be reduced. So this is called diastolic heart failure. This results due to poor ventricular filling because of defective relaxation. Both the systolic and diastolic heart failure coexist in some of the conditions like myocardial infarction. We have another type of heart failure called as high output failure and low output failure. What happens in high output failure? Here the cardiac output is always high, though according to the definition of cardiac failure or the heart failure, there is inadequate cardiac output, so inadequate tissue perfusion, right? That is the definition of heart failure. But in case of high output heart failure, the cardiac output is adequate. It remains high. That is at the upper limit of normal cardiac output, 3.5 liters per meter square per minute. Even though cardiac functions are depressed, the cardiac output remains high. For example, fever, thyrotoxicosis, anemia, beriberi. In all these conditions, we have something called as hyperdynamic circulation. That is, more amount of blood volume is present. So, more cardiac output is present, but the heart goes for a failure. Low output cardiac failure, in this state, cardiac output remains low. It is at its lowest limit, 2.5 liters per meter square per minute at rest, and also in stressful conditions. In case of stressful conditions, it becomes further depressed. The heart becomes further depressed. As in the case of heart failure, secondary to ischemic heart disease. The best example here is ischemic heart disease, hypertension, valvular diseases and pericardial diseases. So what are the clinical features of the heart failure? Clinical features of heart failure can be it is given in a gist. Because of decreased cardiac output. In case of heart failure, we have decreased cardiac output, right? So because of decrease in cardiac output, decrease in tissue perfusion, there is more amount of fatigue. There is easy fatigue. The person feels tiredness, weakness, hypotension. There is poor tolerance to even mild exercise. For example, the person roams around inside the house itself, he feels fatigue, he feels uneasiness, weakness. Oliguria, urinary output is also reduced. This is these symptoms are due to decreased cardiac output. Increased left ventricular end diastolic volume because of increase in preload. What are the symptoms which occurs due to increase in preload? Cardiomegaly. This is one of the signs. These are some of the signs of heart failure. Cardiomegaly occurs. There is enlargement of the heart. Dyspnea occurs. There is difficulty in breathing. Orthopnea. That is when the person lies down. When the person is in supine position, there is difficulty in breathing. We call it as orthopnea. Pulmonary edema occurs. There is increased congestion inside the lungs. We call it as pulmonary edema. Increased right ventricular end diastolic volume leads to increased circulatory volume and hence we see raise in jugular venous pressure. There is edema all over the body, ascites and hepatomegaly. Edema especially in the limbs or the dependent areas. We also see ascites and hepatomegaly. Because of increased sympathetic discharge, we can see increase in the heart rate, that is tachycardia, and increase in urinary output. So these are some of the signs and symptoms of heart failure. Now how do we diagnose? Diagnosis of heart failure is mainly based on clinical features, followed by which we do some of the investigations. The investigations is going to establish or it is going to find out the type of heart failure, severity of heart failure and the complications which has occurred. So what are the investigations that we can do for a person with heart failure, or when you are suspecting a person with heart failure, we do following investigations. First of all, electrocardiography ECG. ECG findings may reveal arrhythmia, ventricular hypertrophy and myocardial infarction. Then we can also do radiography of the chest. Radiography of the chest shows enlargement of the heart, congestion of the lungs and certain valvular defects. If there is any calcification of the valves, we can find out with the radiographical pictures. Then some of the biochemical tests, which includes estimation of blood urea and electrolytes for renal failure, hypokalemia and hyponatremia. These are some of the investigations we do for establishing the heart failure and to find out the complications of heart failure, severity of heart failure. How do we treat such a person? The basic principles of treatment of heart failure is to remove the precipitating factor. If there is constrictive pericarditis, we treat the constrictive pericarditis. If there is stenosis of the valve, treating the stenosis of the valve improves the cardiac ability. Correct the underlying cause, control the congestive heart failure state and prevent the complications. In general, following measures can be employed for the treatment of cardiac failure. First of all, to reduce the cardiac workload. The person should be given complete bed rest. The patient is advised complete bed rest or patient is hospitalized for 1 to 2 weeks. Small or light meals are recommended. Heavy meals can also precipitate the condition. Drugs like sedatives and anti-anxieties may help to certain extent. To improve the myocardial contractility, in order to increase the contractile ability of the heart, we give certain drugs called cardiac glycosides. The best example is digitalis. And sympathomimetic amines like dopamine. Both of them are going to increase the pumping ability of the heart. To control fluid retention, because of increase in preload, the heart failure symptoms may become exaggerated. So in order to reduce the preload, we need to reduce the fluid retention. So dietary salt restriction and diuretics are given. What do you mean by diuretics? These are some of the drugs which are going to excrete the excess fluid from the body. We call them as diuretics. So salt restriction, fluid restriction, and giving diuretics to throw out the excess water from the body in the form of urine. To reduce the afterload. To reduce the afterload, we use certain vasodilated drugs, especially angiotensin converting enzymes like enzyme inhibitors like captopril and enalapril is recommended. ACE, we call it as ACE inhibitors, angiotensin converting enzyme inhibitor. The cardio-specific drug, ACE drug are captopril and enalapril. These are some of the basic modalities of treatment for cardiac failure or heart failure. So this is all about today's class. So we learned what are the different types of heart failures, what is the pathophysiology of heart failure. We also learned what are the symptoms and signs that is going to be developed in case of heart failure. Then we learned little bit about the investigations done and the treatment modalities for the heart failure. Right? So this is all about today's class. Followed by this, now we will have a practical session. I will be briefing you about the practical session, and I will also forward a video related to that. Okay? Thank you.